So we're gonna see more.
It was long enough for you, but yes, they
Oh, the name is so hard.
Testing.
But they didn't know that this was oh, I got 4 minutes. I did too. That was my number, like the similar kind of question. Did you get that? I left my number for you. I did. I put it away in my purse. Okay. At first I was like, I see, this is not Kim's binder. Maybe Kim was sitting there like, oh no, this is mine. Yes. Yeah, but yeah. Yeah. Or if you know somebody else towards me that didn't see anything. Oh, yeah. Yeah. I just wanted to get into that, you know, so like, my situation. Yeah. Exactly.
All right. I'm just testing. Testing. Anvia, can you hear me outside? I'm not picking you up. Can you try speaking? Sorry about that. One more time.
Testing. Hello? Can you hear me, Lynn?
I can hear you. Just say a couple sentences.
Okay, I'm walking around the library right now, walking towards the children's room.
Okay, that's perfect.
Okay, great.
Thanks very much.
I'm back.
time. Trust me, I can do it right off.
I did.
Just testing. I'm just doing a mic check really fast. Mic check. 1, 2, 3, 4. We know the mics work in here. It's for folks recording.
Okay. This was 60 to re-enter to 90. Mhm. And then what's that? Okay. And where are the mics? I mean,
Are all the mics at full charge?
what are we doing for that?
This will be empty. Here we go. Thank you very much. There we go. Thanks.
All right. Maybe we can make our way back to the table, please. We're going to hear. We're going to hear. We're going to hear.
Kevin, are you ready for a mic check? All right. Testing. 1, 2, 3, 4, 5, 6, 7, 8, 9. 10.
All right. Do I have my group?
Mic check. 1,
Come
2.
on back, everybody.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27.
Is anybody going to be over at the back? I can do it. I'm afraid I'm going to lose track of the pro-con. Whose turn it is? But I can probably ask Shelby to stand next to Cain and see, and she can just point.
That sounds great.
Sorry.
All right. We're almost ready.
I was going to ask Shelby to do
60 to 90. So it'll be easier.
All right, it looks like we're still missing a couple of people.
Exactly the right moment when you're going counting down.
And they get cut off. So
You let the buzzer go, right?
Come back. Come back.
I know that, yes.
oh, please be. Huh? Please be. Oh. Who else are we missing? Dylan. Dylan. And Jake.
I like golf.
I like Snap.
She's gonna call us all back. So, yeah. Thank you.
Okay, we're still missing a few people. Anybody know where our fearless panelists have gone to? Oh, good. Oh, there we go. All right. Give everybody a couple more seconds. I hope you had a good lunch. I think they're feeding us well. Thank you very much, Sam, for the good food. All right, we're still waiting for one. So give a minute and then we'll get started. I'm curious. Okay, great. All right, we're all back. Thank you so much. Well, this is your opportunity to hear from people to answer those questions that you worked on so hard this morning. So, yay, go team. I think it's terrific. Here's the way this is going to work. I'm going to call up to this table both sides, the advocates from the con and the pro side. They will each reintroduce themselves to you, but they will only have 60 seconds, and I'm going to reverse the order and start with the con side at this point. You all have created 5 questions, top questions that you would like to ask them. So we're going to move through the questions. We're going to start with a coin toss, and that will determine which side gets to go first to answer the questions, but both sides will be answering your questions. They will have 90 seconds to do that. We will use the same system that we used yesterday, which is this sort of combination of buzzer and mute the mic system. And once we get through the 5 questions, you will have an opportunity to ask more questions. This session will last about an hour. Okay? Any questions about this, the way we're doing this? Okay, and did I miss anything?
Do you have a question?
Oh, Christine.
Okay, one second.
If their answer brings up more clarification questions, can we ask them at that time or write them down for later?
Write them down, but make sure that when it's time to open it up for questions, you flip your tent, okay? And then you may want to refer back to that question, okay? Any other questions about the process? All right, so maybe our advocate panels can come on down. Come on up, come on over, come on in. Are they all in here?
They're all in here, and if they can pass if they wish.
Okay.
60 seconds a person per side.
Per side. 60 seconds per person or per side?
60 seconds per side.
Yeah, that's
Side.
right. Okay. I bet you're all wondering why I have this Harry Potter sorting hat.
Yes.
Well, first of all, I'm going to put you in Harry Potter houses. But more than that, the 5 questions I'm going to ask you all to read. But in order to determine who's the reader, I'm going to pull your name out of here. You may pass, okay? So if you're not interested in reading, just let me know and I'll pull out another one. I will not tell you whether you're going to Gryffindor or Slytherin, as tempting as that is. Thank you. Okay. Just to clarify the instructions, the reintroductions are 60 seconds per side, not per individual, okay? So make sure that the mic is at a good distance. And in fact, I would like it if you would, who's doing the reintroductions over here? It's just one person, 60 seconds, to reintroduce yourself to the group. I just want to test the mic, is all I'm doing.
Hi, Terry Hudson Jinks.
Okay,
Medical Center.
there's a little bit of an echo.
Yeah.
Let's do that again, and then we'll bring it down here and test the mic.
Testing. Good morning, everyone. Testing.
Can you
Good
hear that?
afternoon.
All right. Just make sure when you all are speaking into the mic, you're at a good distance, okay? Do you want to test yours real quick?
Testing.
Okay. Everybody can hear? All right, good. So I'll leave this one down here. So the con side gets to reintroduce themselves first. And as I said, one person does it, or you can split it up if you want, but you only have 60 seconds.
Good afternoon, I'm Nancy Gaydon. I'm the Chief Nursing Officer at Boston Medical Center.
Hi, Terry Hudson Jinks, Tufts Medical Center, Chief Nursing Officer.
Hi, Donna Glenn. I'm the Associate Dean at Regis College. I'm the President of the American Nurse Association, and I am a nurse scientist for the VA Boston Medical Center.
Hi, I am Karen Coughlin. I'm a registered nurse of 34 years. I am a staff nurse at the Department of Mental Health at Taunton State Hospital.
I'm Deborah Berger. I'm a staff nurse. I am also president of the California Nurses Association, and I'm president of National Nurses United. I've been a registered nurse for 46 years.
Hi, I'm Dr. Judith Schindel Rothschild. I'm an associate professor at the William F. Connell School of Nursing at Boston College, and I am the faculty advisor for the Massachusetts Student Nurse Association and a fellow in the American Academy of Practice.
All right. Terrific, thank you. All right, so as I explained when you were in the back of the room, you're going to have 90 seconds to answer questions. You will each have a turn to answer each of the 5 questions. People around the table will ask them. They have identified the top 5, and then they will open it up. In order to determine who goes first to answer the questions, I'm going to flip a coin, and I'm just going to say the tails goes to Con. And it is tails. So you will go first. And the questions, you all have them in front of you. All right, so the first reader, should have gotten my little anthropology glasses out. It's Russ.
Benefits and shortcomings have arisen as a result of implementing the 2015 ICU.
You're going to have to speak.
Really? I can hear myself. Okay. What benefits and shortcomings have arisen as a result of implementing 2015 ICU staffing, and how does this shed light on potential impacts of limits in other units?
Hi, I'll take that. At Tufts Medical Center and throughout Massachusetts, the 2015 implementation of ratios in the ICUs has not had any benefits. It has provided severe restrictions to access of patient care delivery. I talked about the neonatal ICU yesterday, and as a reminder to that, we have needed to split twins in an assignment, split triplets, and have delays in accepting babies, and at times, regardless of what the nurses think about their ability to accept admission, at times we've had to deny access to our neonatal ICU. There are only 8 neonatal ICUs in Massachusetts. In other ICUs, regardless of the wellness of the patients in the beds, even if those patients are ready to go to the med-surg floors, the nurses cannot accept a patient. Even if report is given and is patient in need in the ED or in the OR that needs their care, and if they want to accept that patient, then they're breaking the law. What they think about and what they tell me is they're afraid of breaking the law, and their fear is that their license is in jeopardy if they do so. They worry constantly about the wellness of those patients they can't meet needs of.
I just want to add that the emergency department example for us, if a patient's in the emergency department and they're a critical care ICU patient, we have to keep them in the emergency department until.
Okay, and then we pass over to here.
I have looked at the impact of the ICU law in Massachusetts. The first point I want to make is that it became fully implemented in 2017. So there wasn't a significant decrease in the number of the limitations to nurses until 2017. When we looked at nurse-sensitive outcomes, there was an improvement with the outcomes measured in 2017, like catheter-associated urinary tract infections. Many of the Massachusetts hospitals, I did an analysis in calculating the costs, already met the standard. And so we were talking about the outlier hospitals. For those hospitals that remain outlier hospitals, we have a score of all the nurse-sensitive outcomes. It's called a safety and adverse event score from the Centers of Medicare Services. And that is significantly different between the hospitals that meet the standard and those that don't.
In California, when we implemented the law, there were no issues with staffing as far as the emergency room and transferring patients from the emergency room up to the ICU and getting care in the ED. In fact, the wait times to get to the hospital to the level of care that you need was greatly improved, and we improved actually our stroke.
One for the tables. Okay, our next person is Charles.
Question number two.
No, you need the mic, please.
Who came up with these ratios, and what proof is there that these can be applied to all hospitals regardless of size and improve patient care?
Can you say it again a little bit slower?
Sure. Who came up with these ratios, and what proof is there that these can be applied to all hospitals regardless of size and improve patient care?
Thank you.
So I'd like to say that to ensure patient safety, these limits actually were developed by nurses for their patients based on the best scientific research that is out there, established professional standards, and interviews with nurses from across the state working in all types of hospitals. In addition, they also took into account the experience with this law in California and that has been in place for the last 14 years. And I would say that what this does is that it sets a standard of care across all hospitals in Massachusetts, regardless of size. It sets a standard.
I looked at the hospitals that meet the standard and those that don't, and I looked at factors, whether they take care of more Medicare patients, their size. There's no difference between the hospitals that meet the standard and those that don't, but there is a significant difference in outcomes. So there is no difference between the hospitals that currently meet the standards. The standards are applicable regardless of the size of the hospital. It's the intensity of care the patient needs on different units.
And in California, we have a variety of facilities, large and small. The ratios actually work in all of those facilities regardless of size.
So these ratios were developed by the union. I know of no other nurses outside of the Mass Nurses Association who were interviewed or represented in developing these ratios. And as we look at California, there still continues to be no research that these ratios were effective. Let me also add that the Massachusetts ballot question is quite different than what was implemented in California. California's implementation was prolonged. We're looking at a month and a half to implement this. The numbers are different in California. California utilizes LPNs, ours do not. So to make the reference that California works, so it should work here, is like apples and oranges. The other point that I'd like to make in the ratios is there is no research that says that the ratios improved patient outcomes. The research states that the improvement comes from a variety of things, including experience, the culture of the unit, and the healthcare team.
Just want to say too that Dr. Schindler Rothschild's work was all done on averages of the number of patients in the hospital and the number of nurses in the hospital at midnight based on the data that she was able to get. So that is not what this ballot is asking for. This ballot is asking.
Is there a third mic?
Nancy, I have it. Just leave that one on the table.
Good. Okay, good. So our next one for question 3 is Dawn.
What would the protocol look like if a family of 4 arrived to the emergency department with life-threatening injuries and the ED was at capacity or had reached its max according to the law?
This would create quite devastation in the emergency department. Nurses would care for the patients in need, worry about the patients in the waiting room, and be extremely distressed about the patients who had needs and an inability to meet them. It would close the doors of the emergency department, and regardless of patients' needs, patients would wait. Ambulances that were bringing patients to the doors would line up outside the door, and we have visions such as California as ambulances just stacked up, waiting, unable to respond to 911 calls. And all the while, care providers, physicians, physician's assistants, and nurses really worrying about the patient needs that they could not met.
Yeah, the emergency department is probably the place that I'm the most concerned about because of the moral distress of the staff. They could have 3 patients that are stable and fine, and this law would prohibit them from getting another patient from the waiting area. And just a little bit on the analysis for the ED, in Dr. Schindler Rothschild's work, she states cost estimates for the emergency department were not calculated for non-stable emergency room patients. And so for us at Boston Medical Center at this time of the day, about 50% of our patients are non-stable. So to plan to meet this law the way it is written, not the way we might wish it was written, but the way it is written, we would need to staff every day of the year.
All right, first of all, I'd like to say it would look exactly like it looks today if a family of 4 shows up in an emergency room with life-threatening injuries. They are going to be seen. They are going to be attended to. That is an emergency situation where they would need to be seen. In addition, there would actually be more nurses in the emergency room departments than there are now. So those patients would still be seen. We are not going to turn away any patients from Massachusetts emergency rooms. We have a law that, and it's not going to happen. This is a fair tactic that the Hospital Association and the opposition is putting out. This is not going to be a violation of the law. Egregious violations of the law would have to go through a number of certain things in order to be met. So what I would say is more nurses, more resource nurses who are used in the EDs and everything else. And at this present time, Massachusetts EDs, wait times in California are 47 times percent shorter than here in Massachusetts. And we now rank 48 out of 50 for the longest wait times in the nation. This, having more nurses in the ED, will actually improve patient care in our emergency rooms.
So I have a published article, Journal of Emergency Nursing, an additional 3 hours of additional 3 patients.
Okay, question 4. If I could get Kimberly to read it.
What are the current nurse-patient ratios compared to those proposed?
All right, so currently, the current nurse-patient ratios, the only place that has limits in Massachusetts is the ICUs. The only place.
So let me finish quickly. My last thought. The article was published in the Journal of Emergency Nursing that was heralded by the editor of the Journal of Emergency Nursing, looked at Massachusetts hospitals, wait times, and RN staff. When you add an additional 3 patients, that doubles the wait time in 24 hours. So 1 more patient per shift doubles the wait time from 30 minutes to 60 minutes. So it makes a difference. I found in my study doing the cost analysis, 59% of the mass hospitals meet the standard in the ED, 52% currently meet the standard in the step down, 36% in med-surg units, and 10% in behavioral health. That's right now.
I'd also say what this does is it places a standard of care so that every patient in every hospital, in every unit in Massachusetts receives safe patient care. As it stands right now, nurses in some hospitals do not have the ability to flex down on their patient assignments to meet the needs of their patients. They are being assigned too many patients to care for at one time. And this is what this does. This sets a limit on the number of patients a nurse can be assigned in a hospital unit at one time for the safety of the patient.
So I'd like to start with just a quick point. The Emergency Nurses Association is in opposition of this bill. And my second point is the mandate can only be lifted in the state of a public health emergency declared by the governor. And the last time that occurred in Massachusetts was in 2014. This mandate cannot be lifted the way that it's written due to accidents.
Further along the emergency department, the Emergency Nurses Association and the Massachusetts College of Emergency Physicians just published an article recently, mandated nurse staffing ratios unworkable and harmful to the community. They're extremely concerned about this dangerous situation.
Just want to add about the nursing areas that are meeting the law based on the analysis that with the data that you had, which is the midnight census, it looks like Boston Medical Center meets the standard today, and we do on the average in 24 hours. But the problem with the rigidity of this law would be that we would not be able to flex within that time, and so that's why the calculations are so extreme. When we go hour of the day and unit by unit, we know exactly what it would take to have such a rigid rule.
Okay. All right. Our next question, I think it's number 5, is going to be read by India.
1 second. I'm going to have the mic passed to her.
Okay. How do you know how much staff you will need in the ED when you do not know if they will be busy or not?
I'd just like to back up to the ratio question. For example, we, in our organization at Tufts, we come close on average. But just walking through one unit, that unit's nurses decided that they wanted more nurses during the day and evening shift and less at night, so that they can meet patients' needs, meet family needs, do a lot of teaching, and allow patients to rest. That's the difference between averages and ratios. We don't have ratios. We have staffing plans that are changed by the staff nurses based on the needs of patients during the shift and over a 24/7 basis, and differ every single day of the week.
I think I'm going to answer this in the present tense because you asked how do we do it today. We look at the number of arrivals by hour of the day, and we look at the average number of patients in each level of acuity by hour of the day, and we look at the staffing and the changes so that there's many more nurses in the emergency department, say in the afternoon and evening, than there are in the morning. And we overcompensate because, of course, that's just the average. And so we look at the 25th and 50th percent, 75th percentile, so that we make sure that we can manage to the surprise or more than one person coming in and all that kind of thing. The key for us is that we do have the flexibility. If a patient is fine who has their finger getting sutured or something, the nurse can go help in another area. And it's that fluidity that actually makes the emergency departments very safe.
So I would just like to say that there are differences in the emergency room in terms of the number of patients taken care of by nurses. It is an average. But when you look at wait times for patients, they triple. There are more hospitals where nurses have limits on the number of patients, and those patients are seen quickly and triaged quickly, and the patients who are not, some of the hospitals that I looked at, and this is publicly available data, they're waiting on average in some of our Massachusetts hospitals an hour and a half. If you look at the hospitals represented here, it's less than 10 minutes. And if you look at the number of patients assigned to those, on average, I grant you it's on average, in these hospitals that are represented here versus the ones that aren't in this room today, there's a massive difference between 10 minutes and an hour and a half.
I'd also like to say they kind of answered that question a little bit for us because hospitals have the data to show average census on an hour-by-hour basis, on a day-by-day basis, et cetera, that they are seeing coming into their emergency rooms. And they're able to staff on that. And California has proven that they're able to staff on that. And they have nurses who actually, like resource nurses, who come down to the emergency room when needed to assist if something were to come up. And flow to the units is much quicker.
All right, so we're now going to open this up to new questions. So you've got some choices here. You can either use the questions that you all created earlier in the small groups, or if you have new questions based on the testimony you've heard, you're welcome to ask those. So Janice has already turned. Can you ask a question? Yep, go ahead, Janice.
Okay, my is, if the bill that was passed in 2015 took 2 years to implement, why must this bill be implemented in 6 to 7 weeks? That seems ridiculous.
Are you asking who is that?
The pros just finished, I think. Who just started? Right. I know.
Oh, so it's our turn?
Yeah.
Okay, so what I would say is, okay, that is another myth and a lie. It isn't going to be implemented in 37 days. Like the ICU law, it was passed in 2015. It actually wasn't implemented until 2017. And that's because of the regulations and everything else that needed to go along with it. Hospitals, there are a number of things that are going to need to be done before this can be implemented. We need to have hospitals need to develop their acuity tools for each of their units. Those have to go to the Health Policy Commission for certification. They also need to be able to give a plan to the Health Policy Commission as how they're going to comply with this law and how they're going to put it into effect. They also need, the Health Policy Commission also needs to come up with regulations regarding reporting and violations and how will that work in conjunction with the Attorney General's office. So there are a lot of things that need to be done before this law can be, implemented. It goes into effect on January 1st, but in order to be implemented, and there will be no fines would be assessed as January 1st if hospitals are not into compliance because of the need for these regulations and implementations.
Which is exactly what happened with the ICU law. That's why it took so long. Experts like myself testified multiple times, so did other experts. So it's a process. The law passes and then it's a process through our regulatory agencies.
That's their ad.
No follow.
Hi, it's a great question. We recommend all of you read the ballot again specifically. We've heard some inconsistencies today already about what the ballot question says and what's being inferred. They're talking averages of nursing assignments. It's ratios, very different terminology. They're talking it won't be implemented in January. This is saying it will be in January. So we're preparing in the event that this occurs for January and the devastation to healthcare. Third thing, Massachusetts law that went into effect for ICUs was a very different process. The voters didn't vote. We negotiated an agreement and then together with the government structured an implementation time. That's a very different process than we're undergoing today.
Yeah, it specifically says in here that the Policy Commission cannot do anything that delays the implementation of the law or that changes anything that's written in here. It goes into place on January 1st. We may wish it didn't, but that's what the ballot question says, and the voters expect it to vote on the question, and it gets implemented as it's written.
And the devastating effects on that as a nurse educator to try and find 5,000 nurses in that time. And I guarantee you the majority of them will be novice nurses who had just graduated in December, who have a very limited orientation and will then be transitioning into practice in a poor manner.
Okay. It is my fault. I should have given clearer ground rules. One question, sorry. And try not to ask the questions with too much judgment one way or the other. I think we're just trying to get the facts from both sides here. So that's terrific. I think Charles, yeah, terrific.
Geez, I think I've already disobeyed your orders. What happens to the patients left in the waiting room because the hospital cannot admit them, despite having the actual bedrooms, or just not having the proper nursing staff? I know, of course, there's a law that you have to serve anyone in the emergency room, but what happens if you don't have the nurses? Is the hospital going to pay the fine, or are they going to tell the people to go somewhere else?
I work with a physician who was in California for several years after the implementation. He's an ED doc. He said patients wait. So whether you're having a stroke or your heart attack, or your kid fell down, or you're worried about something devastating, you wait. And then the folks inside the doors, the nurses, most of them have a great conscience and want to do what's right, worry and have great duress over the situation. So empty bays, doctors ready, physician's assistants ready, not the right ratio mix, and patients wait for care.
I think that's why all the studies that are written about quality and staffing all have to do with averages, because the right way to manage in healthcare is to work on the average, because then you can redeploy resources. And I agree with Terry. I think that the moral distress will be unbelievable for nurses. They will either have to break the law or not deal with the patients that they feel need care. And that's why the nurses that I talk to about this all the time are very, very, very scared of this.
And that's why the Emergency Nurses Association opposes this. Healthcare is not about averages. There's no average day. No two patients are the same. No two situations are the same. No two nurses are the same. No two units or emergency rooms are the same. But to answer your question, patients will wait.
So I work in California. I have colleagues that work in the ED. Yes, we don't deny that patients will wait in the emergency room. However, if you have a heart attack or a stroke, there are certain protocols that are followed nationwide where there are treatments that patients get immediately, regardless of other patients in the emergency room. There is a definite increase in the better levels of care in California. And I keep reminding people, the wait times in California are 47% less than in Massachusetts. We have the law because we have the resources to absorb all of those fluxes in incoming patients that have critical needs.
And there was a recent study in the Emergency Journal of, I think it was the, about Journal of Emergency Nursing, which showed in Massachusetts recently, their EDs found the number of patients an ED nurses care for is directly related to how long patients will wait for treatment. Wait times in trauma EDs for diagnostic evaluation double for every 3 patients an ED nurse cares for in a 24-hour period. 3 patients added to a non-trauma ED nurse's assignment means an extra 15 minutes waiting for evaluation. The findings in this study suggest that lowering the number of ED patients cared for.
All right, next we'll hear from Christine.
I'd like to go back to question 3, which is about the family of 4 arriving to the ED with life-threatening injuries. Specifically, when the ED was at capacity already as the bill is written with the amount of patient-nurse ratio, as it is written, where does it say, or how could we know that they would be taken care of if it is saying this is the law? How, there's nothing that I'm seeing that's stating it could be overridden. So I just want clarification on that.
Other nurses that are my resource or floats take over my other patients. They have more ancillary staff than she did in Massachusetts. She has the ability to get breaks, et cetera. So more nurses in an ED equals better care and better outcomes. So once again, patients who come in from like a car accident or something like that, they're going to be seen, they're going to be treated. So there is no difference in the level of care. There's just going to be more nurses in the ED. That would be when they would bring in nurses, resource nurses down. They hire more nurses for the ED, including overflow nurses, resource nurses, et cetera, to be brought in.
Away from an emergency
Please
department.
use the mic.
And the experience that we have in California is those ratios are flexed for massive emergencies. I'm in Sonoma County. During that massive fire, the place that I worked, not only did we move the ratios and get rid of all of that, but we also had a massive influx of nurses that came in to deliver. These ratios are flexible based on nursing judgment in all areas, and these ratios are flexible based on nursing judgment in all areas, and
Yeah, we would just encourage you to go back and read what's written and what the voters will be voting on. It says here in your question that you're at capacity with staffing and a family of 4 arrives. It doesn't say anywhere in the ballot question for voters to decide that, oh, that's an exception, you can in. We do have EMTALA rules, but honestly, this is extremely confusing when you're telling nurses what they can't do. Right now, we don't have laws that tell nurses who they can't care for. And that's the limit, one of the limitations of this law. So that family of 4, maybe the ambulance truck is going to call several organizations around the city to find where they actually have access so they can be readily cared for. It's going to equal delay in care, period. And if the intention was to do something different, we really wish that that had been written for the voters to decide upon.
I think that's basically this is not about what we wish that this law could say or what we want it to say. It is literally we are responding to exactly what the law would be, and there's absolutely nothing to suggest that there's any flexibility.
And if there were going to be more nurses, more resources, flexibility in this law, I question why the Emergency Nurses Association adamantly opposes it, and emergency room physicians also oppose it and have published that. There is no flexibility, and that family of 4 will be divided.
Okay, the next question comes from Kimberly.
On question 5, I just, the ratios was the ratios for the bill, how would it affect how you staff emergency department?
Once you have your 3 patients, for example, in this law, you'd never be able to move and do something else for another patient, even if it was only for 5 or 10 minutes. 3, that is the complete assignment of how inflexible it is. So we had to add into the analysis all of the redundancy, essentially, that you would have for every level of patient care. And so the acute patients, they would get what they get today. The difference is the nurses wouldn't be able to move to care for other people and bring them out of the waiting room. So for us, it's mostly the difference between the flexibility of being, once you have your 3 patients in this law, you can't take care of anybody else. I would need 56 more full-time equivalents. It's about 15 more nurses a shift. And that's based on still a little bit the average. I think it's a little bit conservative, but it's millions of dollars. And it's, again, with there's no research that suggests, even Dr. Rothschild, she keeps saying this is about the averages, but this bill is not about averages. This bill is about ratios at all times, 24 hours a day.
At Tufts, we've spent a lot of time analyzing what we would need in order to comply, and it's quite confusing because the numbers of sick patients change each and every single day throughout the course of the day. We don't want to be wrong.
So, sorry about that. So what I would say is, again, we keep on going back to the ED. They keep on going back to the rigidity. There is nothing within this that says a nurse can't help out another nurse, the patient, at any one time. What it says is that they can't be assigned more than the limit for the patients that they're responsible for. Nurses help out each other all the time, and this will not change under this. They also talk about the inability to have flexibility. There most certainly is flexibility. There is flexibility related to the severity of the patient's condition, the experience of the nurse, the physical layout of the hospital, et cetera. And so if you're a critically ill patient in the ED, you require a one-to-one. Patient in the ED, you require a one-to-one. Bottom line, you require a one-to-one, and the nurse that is taking care of you should not have above that limit. So for them to say that, that it is too rigid and that increased times will increase, it is untrue. Workflow, when you have more nurses in the hospital on the other units, also what they call the throughput, patients moving from the ED to other units, it works much easier and goes by much quicker.
And I just have to repeat, in California, these ratios work. We get our patients taken care of in a timely manner, and no matter what is said, in California, our outcomes.
Okay, the next question goes to India.
Okay, so I'm also going to go back to number 3 because something else has come up for me. And so I'm hearing that there is already a law in place in Massachusetts saying that you cannot turn away at the ED. How does the hospital respond to this? You got a new law that may be put in place, and then we have an existing. Does one trump the other? How do you guys respond to that?
I'm going to pass it to Judith, but short answer is nothing actually changes in the ED. We can't turn patients away now, and we won't be able to turn patients away in the future with this law in place.
I think the big difference between the analysis from the Hospital Association and my analysis, which is independent, not paid for by anybody except Boston College, and it uses data from the Hospital Association itself that's publicly available, are the differences between hospitals that meet the standard currently and those that don't, and what the impact is already we know on patient outcomes. So just quickly, the hospitals that meet the standard, patients are seen very quickly in the ED. The ones that don't, we're not talking about a few minutes. We're talking about an hour and a half difference. So and you're talking about 4 patients versus 6 patients per nurse. So those added 2 patients make a difference.
And I would like to add, in California, we also have a law that we cannot turn patients away from the emergency rooms. And even with the law on safe patient limits, we still manage to have less wait times. We still manage to get our patients up to the floors quicker than most states do at this point. And we do not have a nursing shortage in California.
So I just want to again state, please read the bill. All right, please read the bill. The second thing I want to state is nurses aren't the only ones taking care of patients. Should this ballot question pass, we're a team. We have transport, we have respiratory, we have occupational therapy, we have physical therapy. We have multiple departments in the emergency room working as a team. If all the resources go to nursing, gone is our team.
I just want to say, with all due respect, Dr. Schindler-Rothschild, to imply or outright state that these are the costs in Massachusetts when you used 1 to 5 in the emergency room, 1 to 5, when so many patients would be 1 to 1, 1 to 2, or 1 to 3 in this law, it's irresponsible. And to say that in California comes better when it is absolutely not the case. I just have never passed it. They've debated it, they've considered it, but it is a bad, bad bill. And it is so inaccurate. The numbers that you didn't even include maternity. It's not even included in your analysis. Your side is saying that that's the cost in Massachusetts. Maternity is 25% of my impact. So how do you not include maternity? How do you not include emergency department patients who are anything but 1 to 5? And how do you do the midnight census on the average for med-surg when this law calls for at all times and ratios? None of the research is on ratios. It's all on averages.
Okay. The next question will go to Russ, but before we I just would like to encourage everybody who works so hard to flip their tents and ask their questions, because I know you all spent a lot of time talking about this morning. Maybe people who haven't had a chance to ask questions too. So Russ.
We've heard a lot about emergency rooms and maternity wards, but we've heard a lot about emergency rooms and maternity wards. But one statistic that stood out was 10% of behavioral health units currently meet the ratios as listed. How do behavioral health associations and other experts in the behavioral health arena stand on the impact of this ballot initiative?
Thank you. Broadly, I would say that absolutely every organization that deals with patients directly is against this bill, including behavioral health organizations. So the Massachusetts Psychiatric Association, and these are all made up of, that one's made up of physicians, but these are all frontline caregivers. The Massachusetts Association of Behavioral Health Systems, the Massachusetts Academy of Behavioral Health, these are and lots of others, but I guess those are the main ones. And for whatever, I'm not sure if Home Care Alliance of Massachusetts also has behavioral health, but I will say that there are, lists of healthcare and physician organizations against this, and every single behavioral health organization that has come out with a perspective, who's done the analysis, is against this.
So we're trying to get our hands on the opioid epidemic. This bill would strip resources from behavioral health and also from the community. Healthcare has changed. Healthcare patients aren't treated in the hospital, they're treated in the community. And this will pull the nurses out of the community setting, including behavioral health. Sign-on bonuses, and everyone will be working in the downtown Boston hospitals, leaving our communities at risk.
Yes, the estimate is we need an additional 900 nurses in order to staff mental health. And when we speak to mental health nurses, they just shake their heads.
So I'm a psychiatric nurse, and I've been working in the psychiatric field for 34 years, and I'd like to talk about that a little bit. This, I think, was a fair tactic, because let's go after the most vulnerable patients in the state. Why don't we do that? Well, let's talk about those people that actually provide those care and those services to our behavioral health patients. One of them would be Universal Health Services, who owns the ABA system. They made $702 million in profit last year, and their CEO made a compensation of $20 million. The new South Coast Hospital down in the Dartmouth area, Middleborough area, down that way on the South Coast, they have 120 beds. They're actually owned by Acadia Behavioral Health, who I believe, they service 16 states. They're in Puerto Rico and the UK, and they had profits of $2.8 billion in revenue. Trinity Healthcare, out in that just cut beds already out in behavioral health in Providence. Providence Behavioral Health Hospital. They're owned by Trinity Health of New England. They earned $1.3 billion. This is about placing their money where they want to place their money. This isn't about taking care of patients. And this is about lining their pockets with profits. That's what this is about. And I am sick and tired of having my patients be placed on a chopping block.
Okay, next one is from Charles.
A few minutes ago, Donna Glynn said something that we have never heard or read before, which is kind of fascinating. If this law is passed, do we lose other hospital assets to pay for the extra nurses? Why haven't we heard this before, Donna? This is something you should put in your literature. I do hope to hear from the pro side on this. I don't need to hear.
So, and I'll let Deborah talk as well from California. So when you look at what happened in California, there was a shift from non-direct care personnel expenses to direct care personnel. So in addition to the nurses being increased, they also have higher rates of patient care associates and nurse assistants. So their whole nursing staff increased, but they have a leaner expense in terms of administration. So there's fewer administrative costs in California than Massachusetts, and more of the proportion of personnel budget goes to direct care personnel, and that includes more nurses' aides.
Deb might speak on this too, but I just want to let you know that there is language within this that they didn't mention. So I don't know why they were talking about losing personnel in the ED, because there was specific language that was drafted in consultation with SEIU 1199 that represents many of the other healthcare workforce, the transport workers, the unit secretaries, et cetera, that absolutely forbids them to have a reduction in their workforce with this ballot initiative being put forward. And that is another scare tactic that is going out there, that you're going to lose your job because we're going to have to hire more nurses. That is not so.
And in California, the transition actually was a lot smoother than they are predicting. It's not confusing.
So my fear is about this bill. That's my fear, all right? And to talk about there are 6 to 7 weeks from November 6th to January 1st. People are naive if they don't think that the hospitals are not going to lay off non-nurses to be able to balance their budget. I was speaking recently to nurses on an orthopedic unit about this bill, and you know what they said to me? We don't need more nurses, we need more therapists to get those patients up and moving. So we're a team. We're not the only ones caring for patients.
Now, we also worry into the future state if this should go through, because we've learned a lot in the last 5 years about assaults on nurses. Something that wasn't a problem 10 years ago is now a phenomenal problem. What we decided to do together with our staff nurses is put together a team that could say, how in the world do we stop patients and families from assaulting nurses? And what we did is we came up with a new plan, and that was to hire more public safety officers. We train them in de-escalation techniques, and they live in the emergency departments, and they're part of the care team. They have allowed, we've cut our rate of assaults on nurses in half, and we've sustained that now for 3 years. This is just one idea when you look into the future of things hospitals won't have the resources to invest in. Serious supports that support both nurses.
Okay. Next, we're going to hear from Sandra. There you are.
Hi, I'm referring to one of the questions that the group came up with, slightly rewording it. What has the impact been on nurse workload and workplace injuries in California since implementing the law? And how does it compare to current mass statistics?
Thank you for that question.
The con side goes first.
Thank you. I'm actually not going to be able to answer that question specifically about the impact on California, but what I want to say is a couple things about the last comment. The California law, remember, had 5 years to be implemented. So that's one of the reasons it was smooth. But again, I'd like to go back to the fact that the only reason to do something like this would be to improve quality. And there are no studies that suggest that ratios improve quality. None. As a matter of fact, in most of the studies that talk about nurse staffing, at the end it says ratios are not the answer. So we have to deal with what's in front of us. This bill is about ratios. Ratios will not improve quality. And so all these unintended consequences are piled on top of something that has no base. We wrote a letter to the M&A, and in every single case of every single research article that they talked about, we refuted exactly and specifically the quotes that they used were not in the article. They came to different conclusions than the article. There's no research to support that this is the right thing. So that's my frustration.
Along workplace injuries, what we have found effective in Massachusetts is to surround the the nurse with equipment, tools, and staff outside of nursing that can support them in safe patient handling. We've invested a lot of resources and we expect to do so. We have nurses participating in research so that they can help in that intervention. In the event that we need to spend all our dollars on nurses with no proven outcome, we'll need to.
Okay, so in California, one of the unintended consequences of the bill was that it actually showed that workplace injuries decreased by 30% from the inception of the law for LVNs, RNs, and other healthcare workers. The fallacy that it took 5 years to implement is incorrect. There were phase-ins of the law. There were changes in scope of practice to clearly delineate, and employers started implementing the ratios which they thought were going to be put forward because they already knew that ratios were going to be a fact and they wanted to hire nurses. They had no problem getting nurses to come back into the profession that had cut their time or left nursing. And then as far as the conclusions on the research study, researchers analyze the data and provide that. They don't specifically make a recommendation on law and policy because that's not their job, but the data does clearly show that improvements in care happened as a result of the California law, right? And then as far as assaults on nurses in California, we passed the toughest workplace violence laws and regulations, and with that, it did recommend improving staffing to avoid them.
Okay, we only have time for a couple more questions, and I'm going to go to people who haven't actually asked questions so far. So the first one is David, and then we'll go to Jesse. And with David, the pro side starts.
Good afternoon. So if in November, if this does not pass, are you going to go back to the drawing board and rework it and reword it and maybe work with both sides to be more amenable so maybe it will pass in the future? Because I think in the end, this is about patients and nurses and the safety for everyone. So is that something you're going to do, or are you going to come back in 2 years with the same exact thing and try to get it to pass again?
So just to let you know, I'm banking on this passing. So beyond that, we haven't made any plans if it does not. There are certain things and regulations in place related to ballot initiatives and et cetera. So what I would say is that we are pushing this because nurses say they need it. There are nurses in other hospitals, maybe not those hospitals that are being staffed the way that they should be, but there are nurses in other hospitals that are straining and struggling to provide care to patients that they deserve and that they have been trained to do. There is flexibility built within this in order to be able to give patients, every patient in every hospital, safe patient care. The profitability of Massachusetts hospitals is unbelievable. And the reason that they haven't done anything like this is because they don't want to take some of their profitability away. It's got nothing to do with providing safe patient care. And we know that because they actually have taken services because it doesn't provide them with enough money in the bank. You know what I mean? So we see them expanding outside of the state, outside of the United States, et cetera. They've got a lot of money that they could do and invest in patient care, and they're just choosing not to do so.
And outside of the United States, there are 3 states in Australia that also have safe staffing.
The American Nurses Association nationally applauds the introduction of the Safe Staffing for Nurse and Patient Safety Act of 2018. This legislation was filed by representatives from Oregon and from Ohio. This legislation recommends committee-based nursing staffing. So at each hospital, you develop a committee with 55% bedside nurses, and then the nurses have the voice. The nurses decide what's best for their unit. This national legislation, which has been implemented by 7 states, does have penalties, and it's for all hospitals that are Medicare and Medicaid. So this is the solution to the staffing, but if this ballot question passes, we will not be able to access a reasonable plan.
I'd say that's the beauty, having nurses work together who actually know the complement of their patients and distribute the resources as they see fit in the course of 24/7, day of the week, given what their patients' needs are. As far as profitability, we currently have 15 hospitals in Massachusetts who are significantly in the red. If this goes through, that number doubles to 30 hospitals will be in the red, profits lost, not revenue, balance, profits lost. And the prediction, I mean, that's almost half the number of hospitals in Massachusetts. So the M&A continues.
You sure? Your question was the same as David? All right.
Kimberly or India.
Yeah. Kimberly? Say it again.
No, I have a million questions that I can go into.
Okay. So we'll go to India. Thanks.
So a thought came up. This is not my original question. It's number 10 on here. But when I think about the hospital work experiences versus community, to me, they're two very different experiences. And working with a company that is community-based, who employ Commonwealth Care Alliance that employs a lot of nurses in this field, I would like to know, how would this law drive nurses and resources from the community-based healthcare? Whose decision would it be? Is this like an auto-enrolled? Do you have more information on that?
Is it like a?
I'm sorry. So how would this law drive nurses and resources from community-based healthcare? Whose decision is this? Are nurses auto transferred from community to hospital because of this bill?
Okay, I'll just take a shot at that because I'm worried about it too. Think of what we saw in California and what we expect would probably happen in Massachusetts is just when we have tried to push care to the community and to better settings that make much more sense for families and patients, this would put sort of a spotlight back on acute care, and we would be recruiting very, very heavily to try to bring nurses into different settings that to meet this law. And so I'm afraid, honestly, that what would happen is we would pull from other settings. And that's why the Mental Health Association is so worried, the substance use disorder groups, and community health centers. They're worried because they think we would pull the resources, and I think it's likely.
Just going back on the previous question a bit about what we will do in November, we're extremely concerned about having one community of nursing. This has been extremely divisive, and we're worried about that. We all love nurses, and we've all been nurses for a long time. So as a chief nursing officer, it's my job, Nancy's job, and everybody throughout the Commonwealth to make sure we have enough nurses to take care of the patients. And it's our full intention to continue to be the strongest advocates for the nurses. We don't need a law to tell us when to hire nurses. There was a period of time in 2016 to 2018, over 18 months, when just my hospital hired 160 additional nurses just based on the new types of patients we were getting. And it was all based on evaluating what patients need. We keep an eye on outcomes, we keep an eye on quality.
Okay, so in California, there were industry fears about understaffing the community services, understaffing nursing homes, understaffing public health services, understaffing the schools. That just did not happen. The law actually lifted all boats. The number of nurses that went into skilled nursing facilities from the law passage in the implementing in 2004 went from under 10,000 to the statistics that we have in 2011 to over 13,000 nurses in skilled nursing facilities. So we'd have no shortage of school nurses. We have no shortage of nurses in other areas, because what happens is once you have those resources in place and nurses have come back to nursing in the hospital, that frees up those other resources to go into the community. What happened was nurses that were on call because they couldn't handle the stress, all of those nurses ended up picking up full-time positions. So it wasn't that they had to hire new nurses. Those nurses were already there, but they refused to work under the stressful conditions in the hospital.
We have 2,000 part-time nurses right now working who could be active.
All right. Thank you very much. We appreciate your time and answering these questions. Okay, so here, I'm going to work backwards a little bit for y'all. We have two more panels of experts, but they're not the pro-con panels, they're the expert panels. I want to give you all some time to sort of let this sink in, debrief a little bit. And so we've got 4 questions for you that we're going to put up here. And what I think you ought to do is maybe turn to each other, maybe this time in groups of 3 or groups of 2. It doesn't matter a whole lot as long as somebody's got a group to talk to. And we've got these questions for you to think about. What questions were answered for you all? Are there any new sources or facts that seem particularly strong and reliable? Hang on one sec. We need quiet back there. Thank you. Were there any new sources or facts that seem particularly strong and reliable? What new insights emerged? And here's the biggie, what new questions do you have? Because what's going to happen is we're going to bring up the expert panels and it's going to be similar. You're going to have a chance to ask questions. Excuse me. Thank you. You'll have a chance, even I lose my train of thought, wait. You're going to have a chance to ask questions. So what I'd like you to do is take about 15, 20 minutes in the small groups to debrief this, talk about new insights, and then come up with some new questions for the next groups that are coming up here. We're going to time you, and then we're going to let you take a break, all right? So talk amongst yourselves, small groups, then go into a break, and then we have expert panel. Yeah, I know. Well, we have 15 minutes in the small groups. I'm trying to be more specific here because I want to stay on time. The experts are supposed to start at 2:05. And so we have less than 20 minutes. So why don't you take 15 minutes as in your small groups and 5 minutes of a break, okay? 15 and 5. Do you have a question? It's the same. So there's a question on the table. If there are questions about the process, here. Okay. Hang on, everybody. Hang on. Hold on. Wait. Sorry. There's a question about the process, which I should have invited. So hold on a sec. Charles, what's your question?
How can we possibly formulate questions when we have no idea who these experts are and what their field of expertise is?
Are they not in the binders in the back? They're in the binders. In your binders in the back. Okay. Did you have a question, Anthony? The same question? Okay. So in your binders, sorry, my fault. I should have directed you to your binders. Are the experts that are coming in this afternoon? Okay. I think it was a good question. Thank you. Hang on. You just take this off. Hold on.
So they did record out this that's the way I suppose they can just write this down for themselves.
I would think. I can walk around. Yeah. Right now. So I need more.
Could you do the time and do it on like this?
Oh, no, it's not boiling down. There's no processing here. This was meant to be a hair share and then a popcorn. We can do it on paper, that's fine. But we can do it on paper, that's fine.
We have a process.
Need anything?
Take down the word close to the chair. Maybe that might disturb. Oh, fine.
So, are we keeping with this 4-minute intro? Lynn? Are we keeping with the change, the 4-minute intro, 4-minute intro, 2-minute expert?
Correct.
How you doing? Hopefully none of that was on. Go back.
I so appreciate people's level of comfort with the cameras.
Yeah, it's pretty amazing.
I mean, wow. I'm really concerned with that.
If you want to go on a break, you have 5 minutes, 5-minute break, 5-minute break if you need it, 5-minute break.
Just so you know, your email is rejected. Oh.
Good knowledge. They need. Yeah.
Okay, I'd like to ask the panelists to please return to their seats. Panelists are in the room, please return to your seats. See, should I do it?
I use that all the time.
All right, let's see if it works. All right, you say clap first? Okay. Oh, I lost my mic while I was doing that. All right. Give me a round of applause if you can hear me. Thank you, that actually worked pretty good. Okay, so as the panelists are settling down, we're going to ask the folks in the gallery if they could just keep the volume down a bit so that we can really hear everything that's happening here in the circle. So panelists, you have your questions ready? And at this time, we want to welcome you back. We will have our first opportunity. Remember this morning, I talked about the fact that today was going to be all about information gathering. So we've moved from the phase of information gathering with our advocates. Now we're going into information gathering from our expert panels. We have 2 expert panels this afternoon. The first expert panel is ready. So I hope the panelists are ready. Okay, so we're going to ask our experts to come on up. Come on up and take a seat at the table. Your name tags are in place. Welcome, welcome, welcome.
Let me slip in.
An expert that's coming on the screen. So,
I wish I had made a decision about which way I would vote on this.
so okay. All right. So what we're about to do is we're about to have an opportunity to ask questions of our expert panel. Each person on the expert panel is going to have 4 minutes to do their own introduction and to address any questions on our already developed sheet. Do you all have a copy of this? Of our already developed sheet of questions that are within their wheelhouse. So if they have expertise in the area of the question you've already posed, within that 4 minutes, we're asking them to address that question. Okay? After the experts have had an opportunity to address we're going to focus on the top 5 questions, by the way. After the experts have had a chance to address the top 5 questions, introduce themselves, address the top 5 questions within their expertise, then you're going to have an opportunity to ask questions. What I want to remind everyone is please keep your questions in the realm of objectivity. So present your questions as an objective speaker, an objective observer. Try very hard to remove subjectivity and personal expressions from your questions. Okay? When you pose your questions, the experts will have 2 minutes to respond to the question, okay? Each expert who has experience in that area or expertise in that area has the opportunity to respond to the question posed, okay? If a question is directed to a specific expert, that expert can start. We'll rotate the start otherwise. But if if question is directed to a specific expert, that person can start the question, and then others will have an opportunity to address the same question. Okay? So we want to, again, preserve the integrity of the expert information that they're providing. So the experts have been asked not to share their personal feelings about the issue. They've been asked not to talk about how they would vote on the measure. And additionally, to ensure the highest quality of the information, they've been asked to speak only within their area of expertise. So in other words, not to speculate about other areas outside of their expertise. They may skip or decline to answer a question if they feel it's outside their area of expertise. Okay? And you have the opportunity otherwise to ask whatever questions you feel you would really need the answers to in order to move forward in the process. Fairly clear? Okay. Please set the timer. Have you agreed among yourselves who will start? Nothing ever? Well, in that case, we can start here. And if you would, please start the timer, 4 minutes.
Is this on? Hi, my name is Carol Bryan, and I am a senior nursing director at UConn Health. I am a director that is responsible for all of the inpatient nursing units, the emergency department, the intensive care unit, and also the outpatient unit of the NEAD Comprehensive Cancer Center. My career is greater than 35 years. I'm a graduate of Villanova University, where I got my baccalaureate in nursing, and also my master's is from Regis University in healthcare leadership. I've devoted a lot of my background, a lot of my expertise to critical care nursing. I started off as a new grad in critical care and have proceeded in a variety of trauma units from Philadelphia to Maine Medical in Portland. Landed at UConn Health and worked in their intensive care unit until I, in around 2002, started to take on management responsibilities. And then proceeded to my director role about 4 or 5 years ago. I actually was working with an assessment group that was brought into many hospitals in the state of Connecticut that looked at staffing guidelines. So I am the person at UConn Health that is really responsible to develop those guidelines in relation to our needs, acuities, and the development of our staffing guidelines. In Connecticut, we do have to report to the Department of Public Health once a year in January, our staffing plans. So I think right now I'm supposed to look at one of these questions, and I would look at number 4. What are the current nurse-patient ratios compared to those proposed? Now, because I am from Connecticut, and also I have a colleague to my right that is at the University of Connecticut School of Nursing, and so we are not operating, sorry. Oh, I'm sorry. I'm going to take question number 4. Some of these questions, it's a little bit more difficult to answer because of the fact that we are in Connecticut and we don't operate under the rules, legislation of laws of Massachusetts. But what are the current nurse-patient ratios compared to those proposed? Those proposed in the Massachusetts the law that is being presented are really not, from my perspective, are really not that far away from where we are right now. In some areas, they're right on target. Some areas we're actually over. But I do think that the importance of communication and conversation regarding what the American Nurses Association speaks to as far as staffing models is extremely important, because if you don't have that conversation with whether it is the labor unions or the nursing unions themselves, the nursing collaboratives and associations, you really don't know how to develop that communication with the team. Thank you. So I just wanted to say that the second, number 5, is how much staff you will need in the ED. I think that that question was answered appropriately when you look at times of day. We look at times of day and we look at an emergency severity index, an ESI level. The severity index of the majority of the patients that we see between 11 and 11, and we apply that acuity tool to our staffing ratios. So hopefully that answers that question.
Hello, my name is Marianne Snyder. I'm currently an assistant professor of nursing at the University of Connecticut. I'm currently the director of the pre-licensure program at that university. We have about 475 undergraduate nursing students. I've been a nurse for over 35 years. I earned my Bachelor's of Science with an emphasis in nursing from University of Central Florida. I earned my MS in nursing with a concentration of family nurse practitioner from West Virginia University and my PhD in nursing from University of Connecticut. I've had the privilege of moving a lot in my life to see the different parts of our country. I've practiced nursing in Indiana, in Florida, in West Virginia, and most recently in Connecticut. Over the last 20 years, I've been teaching in higher education, all at the pre-licensure nursing level. So I'm acutely aware of what our new graduates in at least West Virginia at the time I taught there and in Connecticut are facing when they embark on their professional careers. I can speak in terms of expertise of having had vast amount of clinical nursing experience as a staff nurse and what it's like to work under various staffing conditions, staffing models, all different shifts, weekends, and everything. So I would be welcome to answering questions from my perspective about that. I don't know that I would have the expertise to address the first 5 questions, but insofar as question 4 is phrased, what are the current nurse-patient ratios compared to those proposed? I can speak from my experience of staffing patterns that reflected actually higher numbers of patient care responsibilities in a variety of units. My experiences do not include the ICU or the emergency room, but they do pertain to all adult health areas, from step down to in all facets of medical, surgical, orthopedic, on down, general, outpatient observation, you name it. I covered a lot of area in all those years of clinical nursing. So I can say that the proposed staffing ratios in the bill, the ballot rather, is it's actually lower than what I personally encountered in all my career. When we did have staffing that was comparable to the numbers reported here, I did feel that I had a sense of higher levels of perceived safety with respect to patient care. I can also say that most of my career, I probably felt like at the time we had adequate staffing in all the different hospitals that we worked in. But there were always going to be times, as I knew as a nurse, that there would be times when the staffing wasn't going to be the greatest. And I had to exercise my judgment that I was educated and trained to do, to know what were the priorities of care at the time when the staffing wasn't at its optimum. But any questions related to staffing, I'm more than to field those and do comparisons. And I think that's it for my introduction. Thank you.
Good afternoon. My name is Jack Needleman. I'm a professor and chair of the Department of Health Policy and Management at the UCLA School of Public Health. I'm not a nurse, but for 20 years I have been conducting research on the nurse staffing in hospitals, its impact on patient care, and trying to estimate the costs of both the increased staffing and the cost savings associated with improved patient care. My educational background is as a health economist and public management, public policy at the Harvard School of Public Health, before getting recruited to the UCLA School of Public Health in 2003. I spent 8 years on the Harvard School of Public Health faculty here. With respect to the questions that I might be able to answer on the top 5, I want to speak a little bit to the issue of where the ratios and the evidence comes from for them. As I said, I've spent 20 years doing research on nurse staffing, patient outcomes, the costs and cost savings associated with improved nurse staffing. I'm in California, but I haven't done any of the research on the California ratios, but I have been a journal reviewer on the for a number of the papers that have been published on the California experience, and I have looked at that prior to coming out here, so I'm happy to talk with you about any questions you have about California. With respect to the issue of where the ratios come from and what the proof is, I would say the ratios have been inspired by the research, but are not fully driven by the research. There are 3 bodies There are 3 bodies of research that have looked at nurse and patient outcome. One compares high-staffed hospitals and low-staffed hospitals and has looked at issues of mortality, has looked at other outcomes, has looked at length of stay, which cost to treat patients. And that research is unequivocal that the higher-staffed hospitals have better outcomes and shorter lengths of stay. A second stream of research has compared within the same hospital patient experience on days when the hospital was staffed below its targets for staffing to the days when the hospital was staffed at its targets or above its targets. And that research is also, I think, fairly clear that when staffing is below target, substantially below target, there's adverse patient outcomes that occur. The third research specifically is on the California experience. I'll save that for a question if you want to pursue that. The other thing that's important here is none of this research establishes specific ratios. What it does indicate is more is better, and the choice of the ratios, particularly med-surg 4:1, has been basically based on looking at where the well-staffed hospitals in these studies seem to be staffing, and then to say that perhaps is a target. But that number is not specifically identified within the research.
Hi, I'm Randy Pito. I'm a physician and I have a degree in master's degree in public health. Spent the past 2 decades in Massachusetts focusing on quality improvement and patient safety. Part of that was almost 8 years at a large teaching hospital in Massachusetts as the medical director for quality improvement and patient safety. And there I got a chance to work with highly motivated, well-trained, passionate people, both in the frontline nursing staff and hospital administration, all interested in improving quality and safety, and often having different viewpoints and different perspectives on how to get that done. I also teach a course for the past 5 years at Brown University. It's called Quality Improvement and the Learning Organization, and that's composed mostly of mid-career professionals in a master's degree program in a school called the Executive Masters of Healthcare Leadership. I'm not going to comment on any of the previous 5 questions because I think my colleagues have done a good job and I really don't have anything substantial to add. I will add one thing. One of the things, one of the roles in the hospital I worked at was helping to administer a thing called the Hospital Survey on Patient Safety Culture. That's AHRQ-supported, the Agency for Healthcare Quality and Research. And that has been used for quite a few years now, and the latest data looks at 2014 data. Some Massachusetts hospitals participate in this. Those hospitals know what their results are. There's no public reported information about those Massachusetts hospitals. I don't know if anyone share actually with the public directly. But some of those hospitals actually come together and work with other hospitals to try to compare their scores and think about best ways to improve. There is one question on there that's a really important question, I think, germane to this ballot initiative. And here's the exact wording. And it's based on what's called a Likert scale, 5-point Likert scale. You select either, I strongly agree with the statement, I agree, neutral, disagree, strongly disagree. So 5-part answer to the question. We have enough staff to handle the workload. Across the nation, based on the 2014 data, the percent was 54%. So 54% of nurses across the nation who took this survey agreed or strongly agreed that they had enough staff. That supports one side of the argument. That means 46% either were neutral or only disagreed with that statement. So half and half. I'm not aware of any information that tells me the Massachusetts hospitals are significantly different from this, based on me not having access to the other hospitals. Range of performance across the hospitals on this issue. But it does cause me some concern when I've looked at the culture, what the nursing researchers will call the nursing environment, of what it's like to work in a very complex environment with so many things besides staffing ratios that impact. The ability to communicate between nurses, to ask for help, which is not an easy skill to learn, because you're supposed to sometimes have it all in your head when you come out of nursing school or medical school, or the ability to reach out when you don't have as much to do with your patients, to go over to Nancy and say, hey, I got a little extra time, can I give you an extra hand? That sort of ability is really important. The ability to go to your nurse manager and say, I've got concerns. There's actually a code word, CUS. I'm concerned. I'm unsure about this. I think there's a safety issue. I could use some extra help. Can you get some nurses? The hospitals can staff quickly up and down. Nurse managers responding to that can make a difference that goes beyond what the exact staffing ratio is and all the other components. You talk about electronic health records and so many other things.
Thank you. Thank you all. At this time, we do have our sheet, and on the sheet, there are questions 6 through 14, which, if anyone would like experts to address questions through 14, we'd like for you to, cue your tent so that we can call on you and you can have the experts address one of these questions.
So I think number 14 is what we're all here about. So, if question 1 passes, how would it affect patient care, in your opinion, or your expert opinion?
So each address gets 2 minutes to address the question. And where shall we begin? The microphone is to your right, Jack. How about we start with you?
As I said, the research base is unequivocal that hospitals with low staffing have poor patient outcomes and longer lengths of stay. The research base, I think, at this point is unequivocal that hospitals with low staffing, staffing below the level needed to care for patients efficiently and effectively, have longer lengths of stay, which increase costs, and poor patient outcomes, more adverse events, higher mortality for some conditions. What we don't know and what we didn't get a clear answer to from the first panel is what the distribution is of staffing in hospitals in Massachusetts. How many fall into that low staffed category? So we don't know what the impact would be. I would expect the impact on hospitals that are low staffed, have real tensions between the nursing staff and the administration, to see that staffing go up, to see patient outcomes in those hospitals improve. What will happen in the higher staffed hospitals is less clear at this point, in part because how those ratios will affect the rigidity of staffing and the need to increase staffing to accommodate fixed assignment ratios has not been clearly established or pointed out in the research. The California research shows real improvements in staffing as a result of the ratios in the low-staffed hospitals. Clear improvements associated with that in one measure of mortality, what's called failure to rescue. And that's really clear in the data. It's less clear with respect to other outcomes.
Any other panelists that would have that within their wheelhouse may address the question?
One of the previous panelists had a discussion regarding rigidity and asked you back and to read the proposal. I think that's extremely important because it really is how rigid is the operationalization of this law if it is passed. That really is going to determine how we affect patient care. If extremely rigid, it will affect patient care in a negative way. If there is a liberalization of it, if there is a collaboration with it, it could work. In our particular institution, our nurses are unionized, and we have a monthly meeting with union leadership and hospital leadership to talk about staffing, to talk about ways to improve, to talk about collaborate. We have staff nurses on that committee. It is extremely important, and I think that that is the way I would answer the question. There has to be discussion, and it has to be less rigid.
Any other panelists?
So speaking from my own personal staff nurse experiences, I know we often with my colleagues would discuss, if we had just another nurse on tonight or on the day shift or during the transition period between the shifts. Most of my career was spent working 8-hour shifts. The last 5 or 6 years that I was in acute care environments, it was all 12-hour shifts. And I know that when we had the adequate staffing, we did feel that we could meet the needs of our patients more quickly and respond to those emergent situations and pick up on subtle changes in the patient's condition and be able to respond, as Jack mentioned, in a situation of rescuing rather than failing to rescue. But none of what I'm sharing with you is grounded in research. It's based on my personal lived experience right there at the bedside with the patients and the experiences that I had. And these were experiences that I had in all the states that I worked in. None of the states had mandated ratios. They did have staff nurse councils, staffing councils with nurses so that they could be at the table and provide their opinion on what would be considered safe staffing. None of the hospitals in which I worked had a union. So I don't know, if things would have been different or not. But I can tell you that when we felt adequately staffed, we did feel we gave better care from a staff nurse perspective.
Anyone else?
So based on my 20 years of experience and not being the expert in this field, I am of the opinion that we have really created talented people in so many of the hospitals in Massachusetts. I am of the opinion that even with those burdens, that hospitals will figure out a way to survive, as the California hospitals have done, even though this is a slightly different law. It will be painful for many people. The cost implications are not clear. There are estimates on both sides. They're dramatically apart, as you know. It's quite likely. But what I've been really intrigued by is there, at least in some studies, they've actually shown some hospitals who've actually done better or at least have not had increased costs, not necessarily in Massachusetts, because of figuring out how to have lower length of stay, less hospital 30-day readmissions, and complications. Now, that takes a lot of creativity, that takes a lot of communication between unions and workforce and everything else. So if the law would pass, I'm not going to start pulling out what's remaining of my hair and saying, boy, I got to start moving to another state because I think the care in Massachusetts is rapidly going down. Will there be pain? Will there be transitions? Will there be times that you as a patient going to the hospital may be less safe? Absolutely. Because there is no hospital in Massachusetts that is safe on every shift, because you have different education levels, different experience levels, different nurse managers that make or break the esprit de corps and the communication on that unit. So going to the hospital is a little bit of a gamble. And so my suggestion is stay healthy, do preventive medicine, when go to hospital, health care.
Okay. Are there any other questions from 6 to 14 that this panel would like to hear the experts address? I'll remind everyone, please let's address the questions and our responses in the most objective terms possible. We recognize John. Microphone, please.
This is question 7, and it's how would this law affect nurses' financial situations, and what would the wider consequences be?
I'm not sure, I don't know if anyone can further explain that question. I think that I've read it a couple different times, and the nurses' financial situations, I think that, if we're talking about overtime, if we're talking about, additional time, am I on the right path there, or any further?
I mean, that is part of it, and then I was just thinking, I don't know, wage increases or decrease, and then like just supply demand, what that would do to other hospitals.
Yeah, I think as financial, in addressing financial situations, you also have to address the budgets for the entire hospital. So what would this mandate affect as far as, adding nursing and adding salaries for nurses, adding positions for nurses, and then looking at the rest of the hospital and looking at your support staff, looking at your ancillary staff, looking at your aides, your medical assistants, and how that really works within the increases that you're providing for the nursing staff. I think that it's really up to each individual institution with the regulatory impact that is now there to come up and devise their plan. I think it may affect each individual hospital differently. I think that if there are unions, that salaries will be protected, through union negotiations. Any further question? 40 seconds.
Any other panelists like to address that question?
What I've read in the literature, looking at both sides of the issue, there are some that will argue that hospitals will be in bidding wars in terms of trying to get more nurses to their agency, depending on how many more they would need if this were to go into effect as law. I don't know if that would happen or not, but one thing that I thought about when reading this question was the landscape of the average age of nurses entering hospitals now. They're very young, but they don't seem to have the mentors of the 20-year veterans working alongside them anymore that I remember having as a staff nurse. And nurses whom I've educated or run into and have worked with in the hospital who are much younger than myself, who decide to leave. I'll ask them, well, what's the reason? They all leave for different reasons. And this younger generation, who I love dearly, embraces the future. They're risk takers. They see opportunities and options. So they leave sometimes after 6 months to a year. But the bigger issue is you're going to have hospital staff with very young nurses. So if this were to go into effect, having mandated ratios, you need some veterans there to help work with these nurses to guide them. And I don't know that all of our hospitals are well positioned to say they have that. But one could also say that because of the potential for bidding wars, salaries could go up. Also, my thought is you might be bringing in a lot of agency nurses or foreign nurses potentially to be able to meet these mandates if it were to go into law. I think that's happened in California.
Any other panelists?
Okay, so I'm going to play the economist here and get very concrete about labor market effects here. Right now, one of the reports on this ballot initiative said there are 1,200 vacancies in Massachusetts, even though the average wages for nurses in Massachusetts are very high. What we don't know is the distribution of those 1,200 vacancies and whether they're currently at hospitals that pay less, and that the opportunities for employment at hospitals that pay more are simply not there because they don't have vacancies. So if this increases the need for hiring at hospitals that are currently paying more, we might see nurses shift from where they're currently working to higher paying hospitals. That may lead to some increase in wages at existing hospitals as they try to retain staff or find new staff. So I would expect some wage impact of this initiative in Massachusetts, probably less than was estimated in the one report that tried to estimate wage effects. When I look at the Massachusetts experience, the estimate in the Massachusetts report is at the high end of the California experience, and I would expect it to be a little bit lower. Where those nurses come from, there are at least three sources for the nurses. One is the part-timers becoming full-time, possibly because the work environment has gotten better. Nurses who are retired looking at high wage to come back into the workforce, who had previously retired. We saw some of that during the recession. Nurses that are employed at lower salaried community-based positions going in, and finally, in the short run, agency nurses coming in in response, we're being recruited from outside of state.
Thank you. Okay, we have David. Okay. All right. So seeing no other requests for questions from our existing list, you all worked really hard on creating additional new questions. And at this point, we have time for you to field additional new questions to the panel. So if you have a question that you would like to have answered, this is your opportunity to tip your tent. Just let us know that you'd like to be queued up, and we'll take your question. Indeed. Just 1 second, it's coming, it's coming. Charles.
Hi, both Nurse Dr. Schneider and Nurse Dr. Bryan said that
Maybe they did.
Just for clarification, Nurse Dr. Bryan and Nurse Dr. Schneider said that the staffing ratios that they want under this law are pretty much the same in Connecticut. Apparently, why are we doing this if they're pretty much the same? I just want to make sure that's what you mean. The new law staff ratios are what you guys deal with daily.
So my reference was that they were similar. I think that there are ranges, and I can tell you in behavioral health, I think what I read in Massachusetts was reflective of up to 6 patients, up to a max of 6 patients. And there was some reference with the panel before about shift work. And, different shifts in a behavioral health ward, you may need, 5, if it's a full ward, and it's 18 beds, and you may need a distribution of 4 to 5 nurses during the day shift, depending on the acuity of those behavioral health patients. But at night when they're sleeping, most of them, you're going to go low. So what I'm saying is that I think that there are very similar ranges. The differences, I think, could be a discussion of staffing patterns on those units based on an acuity tool. Acuity tools are very important, and it's, I think, the way that the American Nurses Association would also like to lead us, if that clarifies.
Would any other panelists like to address the same question? Seeing none, we recognize Sam.
Thank you. What factors contribute most to a nurse's job satisfaction, and could you prioritize?
So this is the non-nurse answering the question. Fundamentally, I think what influences nurses' satisfaction is the ability to do their work. A number of years ago, I was asked by the Robert Wood Johnson Foundation to help them shape an initiative around trying to keep nurses in the workforce. And what emerged out of the discussion in the planning of that was the thing that most concerned nurses was they couldn't get their work done, or they were being abused in some way in their work environment. So that led to the initiative Transforming Care at the Bedside, which gave nurses a lot of freedom to try to redesign their work, and was very successful. And in that, I had an opportunity to actually sit down and talk with a fair number of nurses. So the ability to do their work is critical. That means a good work environment, as Randy pointed out, which transcends the issue of what the staffing ratios are. There are work environments that are very good with good ratios. There are work environments that are good with poor ratios. And likewise, there are some work environments that are truly terrible, even with good ratios. And the evidence is that in those environments, patient outcomes are not as good as when the work environment is good. So good work environments mean support for nurses, ownership of practice, good communications and respect with other folks in the unit, including the physicians, perhaps especially the physicians, and a sense of voice and ownership in the way care is organized and delivered.
How I would respond to that question is that having a sense of autonomy with respect to my practice would probably be number one. And then number two, that I know that I could give safe and effective care and respond to the needs of my patients. And whether that was driven by the support I had with the other colleagues on the floor or based solely on the staffing or the ancillary support staff, but just knowing that I had that sense that I could provide the care for those individuals in a safe way and to respond to their needs most effectively. And to have some sense of control over my schedule and being able to have some power of negotiation and knowing that the work that I did mattered and was effective, that I could see some measurable positive outcomes as a result of what I was doing. There are surveys out there for your own research that are on this very top question. Well, what are the top indicators of nurse satisfaction? And at least one of those that I mentioned is going to be in the top 4. So.
At our institution, we have a nursing engagement survey. We give it every year, and it is reflected, well, it is actually formulated by NDNQI, which is one of our national databases for nursing quality improvement. And out of that engagement survey, it seems like the scores are very similar. The staffing needs always come up as a number one issue for, are they being met, are they not being met? And also communication between colleagues, respect from colleagues, and also involvement of leadership. Those seem to be the 3 top areas of whether, the survey actually gains improvement on engagement.
I won't be able to answer your question in terms of prioritization. I suspect if we look at the literature, there might be additional studies out there that have prioritized that. I'll go back to one of the reasons why people go into health professions in the first place. And that's often to help reduce suffering, comfort, compassion. Most nurses, I believe, still want to spend as much time as possible with the patient. With the electronic health record in many institutions, nurses can work to 50% of their time on the electronic health record, which is a tool that can actually improve patient safety, but often will take nurses away from the patient's bedside. So there is literature, Dr. Needleman and others have synthesized literature that shows that patient satisfaction, all other things being equal, patient satisfaction goes up as staffing levels rise. And this dividend potentially to patients in terms of their satisfaction and the experience of being a hospitalized patient if staffing ratios are higher.
For the next question, we recognize Lydia.
Hi, so earlier from the advocates, we heard a lot about the associations that are against this bill. And so my question would be, do you have any information on the percentage of the members of these associations that are actually proposing this bill? Are the members included in this data, or is it just the board? I just would like clarification on that. Use the mic.
We're not exactly sure your question. One of the things I did before coming to this panel is go to the public website that shows the contributions on both sides. If you haven't done that, that's eye-opening information in terms of who supports the bill. But that doesn't give you a list of all the different organizations that have endorsed it. Some organizations endorse without putting additional money into the mixture. But do you want to refine your question?
So I guess, so who makes up the portion of the board that opposes this bill when we're talking about the Nursing Association? Do those individuals include the actual members, or is this decision made from like the association board?
So we don't have a representative of the Massachusetts Nursing Association, but our nursing colleagues may speak.
I think if your question relates to like the Emergency Room Association, Emergency Room Nurses Association, and who makes up that group for that recommendation for or against as nurses, is serving in a variety of capacities, as is the American Nurses Association and the Nurses Association specific to your states.
Any other panelists?
Okay. India, I'm going to partially respond to your question. The organization of nurses as a profession and is complex. You've got unions representing nurses in specific settings. So you've got typically hospitals, and there are multiple unions that represent them. So the Massachusetts Nurses Association, the principal sponsor of this initiative, is one union, but not the only union. My guess is that they did not formally have a vote within their membership, but the leadership did consult with the membership before moving this forward. In addition to the unions, where you've got Mass Nurse, you've got NICU, you've got the American Nurses Association Union, you've got professional organizations that are organized typically around specialties. So you've got the emergency nurses, you've got psychiatric nurses, you've got oncology nurses. Those typically don't play a union role or representation with business, but they are critical to the training of nurses, certification of nurses, and represent an additional source of professional identity for nurses. They may or may not have taken a stand on this. Again, principally the board with some consultation of the members, but no formal vote.
I would only add, and I think you all know this already, but just for clarification, the biggest contributor beside the Hospital Association to the opposition is the Organization of Nurse Leaders. Now, you understand that if you're in a nurse leadership position in hospitals anywhere in the United States, you have responsibilities not only for the quality of care and patient safety, but obviously the optimum use of resources. Hospitals are constrained and labor is the biggest cost. So it would be not unusual for nurses at that level to be thinking very clearly about the financial implications of this versus the Mass Nursing Association, which is consisting mostly of a lot of frontline nurses who obviously have a different perspective. So from the responsibilities they have, it's very understandable where they fall on this issue in terms of putting support behind this.
Thank you. I believe there is a question for our panel.
Yes. We heard about a lot of the Massachusetts hospitals that are very lucrative and the CEOs making a lot of money. We also know there are hospitals that are not doing so well. My question would be, would this bill cause under-resourced hospitals to be absorbed or merged into these larger entities? Or closed?
When the second panel forms, and Nancy Cain is up here, you should ask that question again. The experience in California was that the financial position of hospitals on average got a little bit worse. And the hospitals that started with low nurse staffing that had to do the biggest increases tended to have lower margins. So they started out in a slightly worse financial position, actually in the middle two tiers, not the worst, but the middle ones. A lot of public hospitals with limited financial resources because they were overwhelmingly Medicaid or uninsured. So the financial positions got worse. Some hospitals in the state, some of the richer ones, Mass General, Brigham and Women, have a little bit more bargaining power to negotiate if this is going to increase their costs, which it may or may not. They have some bargaining power to demand increases in payment. Some of the more marginal hospitals have less bargaining power, in part because they're serving less well-insured populations. And it's possible that the financial position, if they have to substantially increase financing, will get worse. That's the experience for some hospitals in California. Merger with larger, better financed hospitals is a strategy for dealing with that, which we've seen used. Closure or reduction of services, particularly lower profit services, is a second strategy we've seen hospitals use. Flat-out closure has occurred in some cases where hospitals have not been financially viable. I suspect there would be strong efforts to keep that from happening here.
This is a question you actually might consider asking Dr. Cain in the next session. I'm fascinated by the fact that one of the supporters of the law are a number of nurses or leaders, I can't necessarily all the nurses, at the Steward Health Group. Steward, as you know, is a for-profit institution. I'm not in any way denigrating Steward. I think they have certainly good people. But it's fascinating for me to see them supporting that, given that they have quite a few mid-sized to smaller hospitals. They don't have gigantic hospitals compared to some other people. So I, just as a personal fascinoma, I'd love to know, and I haven't investigated why they're supporting it, but I think follow the money is often a good observation in this arena.
In answer to a previous question about the potential financial impact on nurses, there was mention of a potential bidding war for nurses' services. how real is the possibility that this law, if passed, would have an impact on community-based healthcare, pulling nurses from those kinds of services?
That's certainly a question to consider. I'm just not convinced, one, that we even have any hard data to show that that happened even in California, although Jack might be able to address that. And if so, was it solely based on the fact that they now had staffing ratios? My sense in speaking with nurses out in the community and population-based care arenas is that is where they see themselves in their career. That is where they want to be. Now, whether they went there having previously been at a hospital and maybe feeling that this would be a better environment where they could have better control over their practice, or the staffing was, quote, better, if that was ever even the reason why they went there, remains to be answered. I know that there are shortages in the community. I know in my state, we need more nurses out in the community sectors. I'm not so convinced, though, that if you had mandated ratios, that would have this huge mass influx out of the community into acute care environments. If anything, it might be between the acute care environments versus from one completely different area going into acute care. My opinion.
I do agree with Mary Ann. I also think that we may be seeing more nurses come out of long-term care and go into more of an acute care setting, med-surg, geriatrics. I think even more so than out in the community. The community nursing, the nursing profession is very different than the hospital-based nursing. So I think that would be a much more of a dramatic change for them outside of a longer-term care unit.
Very much. At this time, I'd like to invite the panelists to applaud the panelists and thank them for their time. Thank you all. Our time for question and answer in this section is complete, but I would encourage you all to take just a couple of minutes, maybe one or two, to write down your thoughts in preparation for the second panel, which will start promptly after our very, very short 5-minute break. Okay, so just take a couple of minutes, jot down your thoughts, your questions for the next panel. I think that at least 2 panelists mentioned there was a question they fielded that would be a good question for the next panel. You might want to write that down, and then feel free to stretch your legs for 5 minutes. Thank you. Again, thank you. Oops.
How's it going?
I'm good.
Good?
It took me a minute, but
Okay.
nothing right now.
Okay.
It's the same time for the second, right?
Uh-huh.
Not sure with the Skype in, how that's gonna go. I really want to avoid this.
Testing, testing, testing. Now try it there.
Oh, yeah,
Testing,
she's
testing,
getting the mic.
testing. I've been wearing it just a little bit lower than right here. Ooh, okay. Testing.
Working in the end?
And then the receiver was in my pocket, so it wasn't like it was that far away.
Doesn't, is it,
Yeah. But,
can you hear it? Is it working
I don't
now?
have anything to put it on.
Oh, they have.
Excuse me.
I think it might have been just purple karaoke.
So put it this.
Yeah.
If I put this closer to my mouth, you guys gotta tune it down low, because it somehow it just, yeah.
So that's good anyway.
You have another one, that piece is loose, yeah. Yes, I don't know if I can answer from.
I was just saying. Yeah, I did. Tried to do my best imitation of you guys. But we'll do it better. Oh, yeah. Nice, nice, nice. Yeah, which is complicated. It's gonna work. Uh-huh.
So how are we gonna handle that?
Yeah, so the timing is gonna be weird, because they can't see anything, unfortunately, from the way the video works.
So we can see them though.
We can see them, we can hear them, they can hear us. They can't see anything. So I'm gonna be over here on text, like just texting them 1 minute and whatever. But if they start to go overtime, just jump in on your mic because they'll be able to hear you. Oh, please, that's finish up or whatever like that.
All right. And so I've been like sliding the mic among these folks to make sure that they share who starts and stuff.
Yeah, that's
How do I do
good.
that?
Oh, right. Let's see. The moderator has just said.
Who is it, by the way?
Verbally, it's Christine.
Okay. All right.
Totally. Yeah.
I'll just say, Christine, will you address that question?
Yeah, you can
All right,
do that
first.
Or, I mean, usually they, during these, like, you can't just open it up and say, does anybody have expertise on that? And they can choose. But I know you were trying to, like, sort of mix it up a little bit more.
That's what the instructions said, Lynn.
No. Caught on my own instructions.
That's right. That's right. No, I'm willing to change that because I mean they kind of did self-manage a bit. So
Yeah, they
really
pretty
did.
well. I think if you want to open
The
it up.
clock, the 2 o'clock, the 2-minute thing was the most important thing.
Yeah, for
Yeah.
sure. Yeah, if you want to just say, who would like to address that and leave it pretty open to them.
Okay.
Because they'll all get a chance.
Okay.
So I think that's fine.
Okay.
Yeah.
Then that's what we'll do.
The last one we were saying, it's the guys who are speaking a lot. But
yeah.
But even that was with you like actively moving it around. But
Yeah.
hopefully they'll manage.
Okay.
Yeah.
Did you by chance wander through the time when we started this break? Did you know? I was trying to sure we were back on time to get back on our schedule.
For sure.
So for
yeah.
3:15.
I think we started this break like just a couple minutes ago. You said 5 minutes. So I think
Okay,
3:15
perfect.
will be right about right.
Perfect.
Yeah.
Perfect.
So, yeah.
Perfect. All right. So I feel sorry. If I was fussy about the fact that we couldn't write the questions down, I apologize.
Oh, I'm sorry.
I'm just trying not to
I
be
like
trying not to be like. Don't change anything. I have the
Yeah.
Because what I do for processes, like I look at it the night before, and I kind of lock it in my head about what's supposed to happen, and I can do some changes, but when everything starts changing, I'm like,
Yeah.
but I get it. I mean, I'm flexible. I am.
Oh, no. I felt the same way. I was going to come over and apologize to you guys, and then there's so much, I didn't want to disturb you, but you know, I don't want to like be in your face.
No.
It was just, the only issue was that
Well, we want to be fair to them, and that you had told them that they'd get the questions.
as it turned out, actually, Sarah forgot to tell them that they were going to get questions,
Oh,
so
see?
it worked out great.
It worked out great.
But I didn't know that.
I tried to handle the ones that they had as if they were the questions we promised them.
Yeah,
you know, but
right.
so what? It's good, Sarah. Thank you. Glad you did.
Yeah. Oh, no,
Yeah.
I'm sorry. I felt like I was being inflexible there as well. So.
No, everybody just wants things to go well.
Yeah,
you know?
right.
So
I just want to go well.
exactly.
No sweat.
No, nope.
Okay. Thank you so much. Yeah, do all of that. I'm actually just going to need another minute to get her on screen, so I'll give you a cue when I'm ready to go.
And then yep.
No, just go back to the email.
See, it's going okay, right?
Yeah, it's great.
Okay, good.
Can I get you anything?
No, yeah, I'm good. I've got some water. They know you're going on the tour.
Well, that's really election season, so everything's all. I got these guys, you know, they're so green. They're like,
Do you guys know that Christine
I didn't know that. That's the Skype person, right?
That's the Skype person.
Yeah.
So I think we should encourage them to direct whatever questions they have for her early.
Early.
And
So
then
she's
gotta
with us from
disappear off the
3:15
screen.
until 3:30.
I don't know the precise time.
Okay. And I know that Lynn is right now trying to get her to come up on Skype. We haven't started yet because we're trying to get her up.
and are you not thinking of having her on them?
Yes.
But I think they're going to try to do a slow introductions,
No,
and then she's got 3 minutes
I
left.
would be great. Oh.
Whatever you think about that. I mean,
Yeah, that does.
I can't stay for the hour to answer questions alongside them.
Even if she could give us a little more than that, like a half an hour, that would be better. She can't. Yeah. Because this is getting technical difficulty. I mean, it's technical difficulty. We can't get it there. You know. And it's already 3:18. We're supposed to start at 3:15. Everybody has to defer to her. Yes. That running back is working. Yeah. David, there's nothing to talk about.
Finally gets an opportunity to like
It'll be fine. It'll be fine. Let me see because we're already like. Yeah. Waiting for the crowd back again.
It is going out live. Can't see you.
Can you hear me now? Can you hear me? You can hear me? Clap 3 times. Fantastic. We'd like to ask the people in the gallery if they just turn the volume down, and then we're asking the people in the gallery to just turn the volume down, and then we're going to ask the experts, next panel, to come and join us up front. Thank you. Someone hide their heads. I'm going to try to make her too. Lynn, high five. Okay. So we have now 2 panelists in person and 1 past work experience. We're going to give each panelist 4 minutes to introduce themselves and to address any one of the first 5 questions fall within their area of expertise. Panelists, do you have the list of questions? Great. So we're going to, again, ask the panelists to introduce themselves and then to address any of the questions that fall within the realm of expertise. Each panelist has 4 minutes with the introductions.
I'm Cain. I'm a professor of management.
Oh, and please speak in the mic.
This one?
Yes.
Okay, I'm sorry. I'm Nancy Cain. I'm a professor of management at the Harvard T.H. Chan School of Public Health. My background is, I was actually telling Eric, I used to be a physical therapist many, many years ago. I let my license lapse, so no, I can't give any exercise regimes to any of you. And then I went to business school and got an MBA and a doctorate because I was concerned, this was years ago, concerned about the way healthcare systems were run and the fact that most institutions, I also look a lot into tax exemption, whether we're getting value for the tax exemption that we provide to healthcare. And I run a lot of program training physicians to think like managers so that the clinical perspective gets brought into the managerial decision making in a healthcare setting. I looked at the questions and frankly, I don't have direct expertise in any of them. They're at deep, I wouldn't be comfortable answering them. I can only say that I did work at the state government in setting, which I did many, many years ago. One of the big concerns one has in a regulatory situation, you can't keep up with the kind of technological change and, presenting symptoms. To get too deep into how providers operate and dictate things, it's very hard to be relevant and to not do damage. So that is that is my bias. That came more from setting rates at too, and I felt that we were trying to do it at too detailed a level. Reward and punish based on outcomes rather than
Understand heavy burden that placed on nurses, but all medical professionals across the healthcare continuum. I applaud you all for being able to be here and have this discussion today. As part of understanding who I am, prior to my current role, I was the Bureau Director for the Bureau of Healthcare Safety and Quality for the Massachusetts Department of Public Health. And as part of my responsibility when I had that role is, I like to explain it as the head regulator for the majority of healthcare here in Massachusetts. As an example, I had regulatory oversight over approximately 2,500 licensed healthcare entities. That includes hospitals across the Commonwealth. As well, I delivered comprehensive overviews and passing and promulgating regulations as it relates to healthcare matters for licensed entities across the Commonwealth. And an important piece that I want to talk about a little bit to help answer questions today is that as regulators, our responsibility is ensuring patient safety, quality of care, healthcare across the entire continuum. Serve this across the Commonwealth. And the tools at our disposal to be able to do this is both at a federal and a state level. At the federal level, you have what's called CMS for Medicaid Services that is part of the federal oversight over licensed entities. And then at the state level, you have state law and state regulations that are tools for us to be able to do our jobs. It really is important to stress the regulatory process that agencies have to passing regulations. And when you look at the ballot question, there's a number of pieces within the legislation that talks about passing regulations. That's a cumbersome process to ensure that everyone has a say in the process of promulgating and putting together new regulations. To give you an example, anytime you go and have to promulgate a new set of regulations, which this would be based on the ballot question as written, then you have to do a 60-day hearing process so the public can comment on it. At that point, you have to go back to redrafting, and then you have to present it and then file it. Just give that to you as a way to understand while the ballot question itself talks about effective January 2019, the law may be in enforced, but the act enforcement in the regulation of it takes a long time to be able to do. And it's really imperative that this type of thing to ensure the pendulum of the oversight is balanced. You don't have an industry or any individual group that has regulatory oversight or lack of oversight that actually has negative consequences against healthcare. And we're all patients and we all have a vested interest in ensuring that we have this approved process. And in relation to the questions 1 through 5, certainly during my time, ICU staffing was.
Internet connection is unstable, but Lynn assured me I should not worry about that. I'm a professor of nursing at New York University, and I studied the nursing workforce and the organization and delivery of nurse care. I'm also the author of the book Financial Management for Nurses and Nurse Executives, so I know a bit about financing in healthcare. I served for about 8 years on the New York State Hospital Review and Planning Council, which was a committee that was appointed by the governor and positioned by the Senate in New York, and its role was essentially to regulate healthcare in New York State. So I have some experience in regulation. In terms of the one other thing about my background, I did want to do research and quality. And we did find in that study a strong relationship between nurse staff and patient outcomes. We use data from across the United States on all hospitals in the United States. I'm going to tackle question number 5, which is how do you know how much staff you will need in the ED by research. One plans based on what's most likely going to happen. it's very difficult for every city on the seaboard in the United States to have in place resources in case a Category 5 hurricane hit them. The towns are set up.
You lost volume. Okay. Well,
Okay, I got him. Can you hear me now?
yes.
Okay. Did somebody say that you lost volume, or did I imagine hearing that?
No, we did the last saying, and I think it was about at the point where you had 10 seconds remaining.
So that question becomes, who should make the decision about what staffing levels are? Is that a decision that is best made at the local level, or is it in the interest of public safety that that's made by some government agency? The research is, there's one study that was done where the researchers, very good researchers, compared what the patient outcomes were in California compared to New Jersey and Pennsylvania.
Thank you, Chris.
After the implementation of the California
hear me?
regulations, and they found some
Chris,
improvement.
Can you hear me?
Yes, I can hear you.
Okay, you've exceeded your time limit. We need to
Okay.
cut you.
That's fine. I'll answer questions as they come up.
And just so the audience knows, she has no visual on us. So I can't flag her or do anything to show her that she can't see those little signs that pop up and say you have 10 seconds left. Okay.
But Lynn is sending me messages. He sent that said 1 minute and 30 seconds.
There you go. All right. He's trying. So we have heard from our experts on questions 1 through 5, but we have questions 6 through 14 as well. If any of the panel here would like to pose one of the questions 6 through 14 to have addressed by the current panel, this is your opportunity now. Please queue with your tents, and we'll stack up and call on you according to the queue.
I can't hear anything. Is that
One
because
moment.
nothing happening?
The panel is identifying who has questions to ask. Okay, so I believe Dawn is going to pose one of the questions 6 through 14.
What will the implications, if this is be on ancillary staff, also on community staffing? Will it have any?
Each panelist has an opportunity to respond to the question. 2 minutes each.
Would you repeat the question? I didn't see that on the list.
How would this law drive nurses and resources from community-based healthcare?
Okay, I can take a crack at that. It's not clear why nurses leave jobs and why they leave organizations and why they leave nursing. The best evidence that we've gathered in our work is
has to have this mandate to have the staffing level from a regulatory perspective. We would look at it from a compliance. We would look to see if there was non-compliance, and that could be done via a license, what they call a licensure survey under state law, or it would be a consumer claim into DPH to say there's not enough staffing, for example, in an ED. And we would go in and we would have the responsibility to look for non-compliance. Now, from a staffing perspective, the hospitals would be staffing based off the very strict language, and that's what would be enforcing. There's no wiggle room to for a facility to have fluctuation. They use words like should must with the that requirement. Language in the ballot question that states that no waivers would be allowable. And that's typically not a process in a regulatory world that you would always want to have to be able to give a commissioner of, for example, the flexibility to grant waivers. Because care changes so fast, you want to be able to collaborate. You see the downstream impacts of staff become problematic requirement versus other community settings that do not have it. And it would really be the strict of the ballot question itself and not being able to have the ability through a regulation to be able to give an enforcement aspect of that. I just wanted to provide that from a regulatory perspective.
Nancy, would you care to X-age? If I'm not an expert in that.
I think this is Chris Kovner again. I think it's not clear that nurses respond to wages.
I'm sorry, Chris, have you addressed the question already?
Yeah, so I don't do it again. I can't say again.
Oh, my letter.
Oh, unfortunately, 2 minutes limit per question for each expert. So we will move to our next question and on.
It's actually me,
I'm sorry,
Jesse. So can we readdress question 1? I asked again because I don't think it was clearly answered in the introduction.
You'd like to re-ask the question?
Yeah, question 1.
Please reiterate the question.
Okay, what benefits and shortcomings have
Over healthcare and licensing said regulations take a long time. It's because you need that induction, that ability to implement it. The downstream impacts at the time, and the number of beds in acute setting is about 15,000 beds across the Commonwealth. About 8% of them at the time were ICU, trying to enforce that type of regulation. So kind of explain it from that purview. And it was a complicated aspect of making sure.
Well, this is Chris again. As far as I know, I like to randomly assign 100.
We focused on what familiarity of a hospital, all the corridor spaces, the stairwells, etc. So that certainly always plays a role into an enforcement aspect of it. And regulators look at all of those types of things if they're going in for a licensure survey or they're investigating a consumer complaint, because fatigue, etc., is potential alleged investigation for us. So certainly isn't down to specifically your answer overall from a regulatory perspective.
I think the question brings up an interesting point that when you implement a law such as this, it has impacts on both the patients and the nurses. And California has done some studies that suggest that, I mean, again, not terrifically well designed studies, but some studies that indicate that nurses are more satisfied with these higher staffing levels that are required in California. I have not heard of any research being done in California about injuries to nurses.
One second, another panelist like to address the question. Yes, okay. Jesse?
So I did read a study yesterday, and I'll bring it in tomorrow for independent research. So they did actually look at nurse safety and injuries, and they did see that it did improve. I'll bring it as independent.
Any other panelists? Oh, India. We recognize India for questions 6 through 14.
I'm not sure if we asked this panel question number 14, but if question 1 passes, how would it affect patient care?
Absolutely. So the effect on patient care, I think an important aspect I want to make sure folks understand from a regulator's perspective, as a regulator, never regulators didn't have the ability to create regulations, because I mentioned earlier, I think that's an important component to being able to ensure patient safety and quality care, is having that collaboration and that. So I think, when you get from the told the bureau director and this was enforced, I wouldn't be able to help anyone with waivers because it would be too strict. I think that is for you all to consider as well too. You want the ability to have a streamlined, effective process where you can continually collaborate with professionals, especially in healthcare. I'm not a clinician by trade, but the biggest impact in healthcare is being able to have open dialogue and therefore. I think that's the important piece.
Would any other panelists like to address the question?
Well, I think, I don't know, because I don't know Massachusetts very well. I don't know what the current staffing levels are in healthcare facilities in Massachusetts. I suspect, because this is what was true in California, that some of the facilities actually staff at higher levels that are mandated. And what we don't know is, will those places then decrease their staffing levels? Maybe someone else on the panel knows the answer to that. There is evidence that better nurse patient improve patient outcomes.
Any other panelists?
Again, this is not my see, I'm just using generals. But I think one concern might be that if a particular provider doesn't have the right staffing ratio that day, that they might close access. So, a big influenza epidemic, suddenly sick, and if you can't maintain your staffing ratios, close units. I honestly don't understand. I'm sort of with Eric. How do you build the flexibility into the system situations that you face? But sure, people would like to see classroom ratio. I teach, so I'd love to have 10 students instead of 60. But again, sometimes there are trade-offs that you have to make it feasible. So I just worry that a rigid ratio that's not flexible would make it hard to maintain the access levels that are there, when sometimes you might be a little short-staffed, and it is a little riskier, but is it riskier than just shutting the unit and having the lack of access? So again, I don't know there is not enough research done in any kind of scientific way. Perfect.
Previously, and if you address the question of specific panelist, I just went to the panelist. And if you address the question of specific panelist, I just went to the panelist. Everyone still can address.
When you look across healthcare, yes, thank you for that question. I think we've seen this a lot across here in Massachusetts, and we spent a lot of time familiar with the setting that they're going into, stress and burnout on the continuum in itself. That's our concern for regulators' perspective, because those are things that we look at is if there was a non-compliance issue, what led to that non-compliance? Was it because of something was amiss because they were on shift 12 out of 14, they working 2 days in a row, all things themselves, that becomes a patient, it becomes a safety issue, becomes a compliance. So absolutely, I think it is. And when you look at the ballot question, it's to institutions because they're a requirement to staff at that level where the other industries are not. And I think when you look across here, like every piece of healthcare is just as important, not just specific areas. So absolutely, that's a great question.
Chris, are you going to respond to that question?
Yeah, I think there's a misconception about the number of nurses who are leaving nursing. What we found in our research before we started was there were these numbers: 40% of new nurses are leaving nursing, 50% are leaving. And we found that in a national survey of new nurses, a nationally representative sample that wasn't in fact accurate, that nurses were leaving their positions and going to nursing positions in other organizations. Not clear to me from the research, it's a nurse is burned out of their job that precludes them from working as a nurse. At least I don't know the research that they're leaving nursing because they have a high burnout rate.
Thank you. Is there another analyst response to that question? Okay. We next recognize John.
Is it on? Question is, and you may not even actually have the answer to this, but when this was drafted, it seems like very little flexibility established in the implementation phase and the timing for this, which is different from what has been done in California or in other places and other states. Is there any motive for that lack of flexibility or rigidity in the implementation, or any benefit that you can imagine this initiative would have the way it's written?
Thank you. That's another great question.
John, let's rotate to start on for Nancy an opportunity to start the response.
Sure, I understand enough about. Is there a benefit to making a more rigid, less shielding law than traditional than the other ones? Is that the question? And having a more rigid implementation than his. Oh, okay. So I was on a Congress on Medicare 6 years, and we always assumed anything just slamming down on people who are trying to provide service. So generally takes a long time. We lost the visual Christine. I'm not sure if she has audio. But please, Eric, please feel free to address the question.
I can't answer the question of rationale behind the writing of this particular ballot question. I will tell you, I have read it a number of times to make sure I understood it and be prepared for today. There are a number of what I would call regulatory concerns as it's currently written. And I'll just give you an example of a couple of. One is giving regulatory authority to Health Policy Commission. They actually, by state law and federal law, cannot do in oversight of licensure. That is actually on another part of state statute, and under CMS, the state agency to carry out the federal laws is actually the Department of Public Health. So that's one area I would have regulatory concerns of ending it. Another that would be concerning is very rigid, meaning there's no capability. There's a federal act called EMTALA. EMTALA is a federal law that requires hospitals, emergency departments to provide access in the patient and within a 250-foot radius of an ED. So me as a regulator, I'd be really concerned not just about the implementation timeline, meaning the law becomes effective. It's not enforceable yet because it has to go through the regulatory process, but there is some federal issues that would need to be figured out as other state laws on the jurisdiction actually resides in the Department of Public Health, not Health Policy Commission. So I just kind of want to at least give you those concerns.
Christine on the panel.
Yeah.
The next question.
Yes, Nancy, this is a question for you. They asked it of last panel and they answered.
A lot of our unsourced hospitals already have been absorbed to we might call more lucrative hospitals, although not always.
Sorry, can I pause you, Nancy? We heard a lot today about some of the hospitals which are extremely and give money and get up. CEOs do actually make these big dollars, but then you also have the ones that are squeaking by the best that they can. Thank you.
Okay. Well, let me say there are hospital systems that have wealthy and poor and relatively less well hospitals combined, in which the well hospital actually subsidizes the less hospital, and their health systems that I can just name one. Stewart closed a worst performing hospital and could close another or two. They have a different mandate. I'm on the board of UMass Health System. We have the Central Academic Health Centers, and we have the community hospitals. It's been very hard to keep the community hospitals viable, and no desire to close them, but it's hard to keep them viable. And so what we start doing is shutting down services one by one, trying to keep the core viable. But it is not an easy economic situation, especially if you have a lot of Medicaid patients or subsidized plan patients. It's not an easy situation. So the tipping point really is if you go over a certain percent and don't have the loss, you're not going to do as well as an organization that's high commercial and low Medicaid. And that's true across Massachusetts and many other states. So it's not just rich, poor. The payer mix as a whole, poor guys can't.
Focus on private, but those who don't know, the state of Massachusetts does run several state hospitals with significant impact this mandate. Their impact would be close to minus $20 million to be able to meet this mandate. Plus, to the right side of this, that at this point, if I was a member, the staffing limits during my time, even though the administrator did a great job of staff to investigate this type of regulation as well too. So I think, those are other unintended consequences on the state side. And those resources are just as important because they are running to some of the most vulnerable populations across the Commonwealth to ensure diversity in healthcare across the continuum.
Chris, would you like to address the question?
Are you asking Chris?
Chris, yes.
I know I don't have an answer to the question.
Can we recognize?
Who will this be for enacting this legislation, and who will be the oversight agency that enforces it?
Please.
Thank you. That's a great question. As it's currently written, it gives actually licensure and enforcement to the Health Policy Commission. This is where I have a word rubs up against another state statute and the federal law, which gives jurisdiction to the Department of Public Health and the Bureau of Health Safety and Quality. They're the actual ones that have jurisdiction to enforce hospital licensure here in the Commonwealth, both at the federal and the state level. So that would need to be some type of legislative fix if this was to pass, because the Policy Commission cannot do it. I will say that during my tenure, on average, there was about 14,000 complaints. 8% of the time, we're investigating conditions of participation violations because their investigation is far more complex. You have both going into the investigation, and the jurisdiction lies within the expertise within the Department of Public Health, who have registered nurses, advanced practice nurses, licensed social workers. So in reality, would need to be a legislative fix to move it, because it would be right against federal state current law. Jurisdictions do not reside in Health Policy Commission. So hopefully that answers your question.
4 years back, it really is a multifaceted question. So there's a direct cost of having perhaps the lower staff having to hire more people. That's going to add costs. Now it could reduce. It may mean more can get. In California, they've had an array.
And we only have a few more minutes. So we have in the queue Sandra, Christopher, and I recognize now that Kimberly has tipped her tent. So we may not get to everyone's question today. Unfortunately, is our last opportunity to ask questions. So what I'd like to suggest in order for us to be able to ask all of the, is maybe if we take all 3 questions and allow the panelists to answer a question that is pertinent or to their expertise. So come around and just state what those 3 questions are, then maybe
Your hour, by day, by month, reported, enforced.
We've heard a lot from the nurses leaning one way or another.
In the emergency department, what other beds or services, but so to maintain that level of staffing at all, what else is happening is probably a safe proposition in my opinion. But again, I don't feel there's enough research out there to make sure that the benefit out.
Nurse to patient regulators to work with industries to make sure you all think about too is you don't want RNs working at the top of their license, right? I want them to be able to assess and monitor patients and knowing the things that are not fully utilizing their.
the next step. Remember, our task is to get to those findings. Our claims need to be clear, strong and reliable, so they can morph into findings. So what I want to ask each person to do now, take a couple of minutes to make notes about what owned and what all have heard. And then we're going to move right into a section, talk about what we've learned and what we've heard, okay? So just take maybe 3 minutes to jot down what you've learned. Okay. Thank you. All right. Now, this time, we're going to go about this just slightly differently than we have previously. Previously, we sort of did a popcorn. This, we're going to just start with the mic on one side of the room and just move all the way around. You can pass, but what we're asking you to do for the first go around is to just give your reflections. Can you hear me? Just give your reflection, but just maybe the very top of mind, what questions were answered between the moderator panel and the expert panels that you heard today. What questions were answered? And we're just going to start with Fox and we'll move all the way around. And again, you can pass if you don't want to respond. But if you would, we'll all hear what each person is thinking. Okay, when you're ready.
Right. Hi. I'm actually still assessing the questions here.
Okay.
So I am going to hand it over to the next
Pass. What questions were answered? That's the only one we're responding to right now.
Questions 1 through 5 were completely answered very well.
What questions were answered?
Well, the question that I think we're all concerned about with the implementation of the new bill, if it passes, quite some time to go through all the other regulatory processes that are necessary before it's acted.
I think they all were answered. Whether or not we got a clear answer, I don't think we got a clear answer for all of them. But for me, I still didn't get a clear answer. They're both.
Well, oh, I'm sorry, we missed the question. I'm sorry. Then go ahead. The original had 5 questions, and one of them was what was answered. So go ahead and respond to what we did as well. We lost a question along the way.
No, I feel.
And I developed a lot of clarity, perhaps behind some of the reasoning for the different positions for the proponents and the ones that were not, and they weren't even spelled out that clearly in the initial claims.
Really?
I learned that, like, and as stated in question 1, it's going to take effect January 1st, but it actually takes months, if not years, to implement it.
Dylan?
To the extent they can give us, like, but I think we maybe do have more questions.
Yes. On? Yes.
Just on what David said, I mean, questions were answered from points of view, and the experts, I thought particularly the second panel, there were some concerns raised by Eric about regulation and the rigidity by Eric about regulation and how that might affect the state's ability to regulate this question. And that raises more questions for me.
Hi, most of the questions were answered, but my understanding from the debate point of view is that I think we have what I learned from the panel, the second panel, is that we have overstaffed nurses, and what we have to do is implement the plan in such a way that we can make use of those nurses in the most efficient manner. And if we can plan the whole thing, the administrative wise and the financial wise, I think we can handle the overstaffed nurse and make use of the from them.
I feel that all the questions were answered. I have plenty of notes by everyone, essential situation, and what would the consequences be? And to add to that, how would it affect the circumstances of the administration and investors?
I think the biggest question that was answered was implementation. I think a lot of people already said that.
For me, I feel most questions were answered, but I think a lot of data is missing, and you need a little more information on what would happen overall to the patients and the hospital.
We seem to be on the list and have to figure out what everyone else. Apparently, we're asking if all of these questions have been answered.
What question has been answered?
Well, I'm not prepared to answer that question at the moment.
Okay,
Sorry.
you can pass. That's fine. So the next question, though, is what new facts, sources, or facts seem particularly strong and reliable? And why don't we have maybe 3 or 4 people to this one? What new sources or facts seem particularly strong and reliable? I see Kimberly's tent. I see Russ's tent. I see Dawn's tent. Russ.
I think the former director as a new source of information and the facility was able to preside and provide regarding the implementation timeline, as well as the regulatory concerns about being able to adapt to community needs, etc. I think that was a new source of information that was particularly strong and reliable.
Dawn?
For me, it was the fact that you're going to need a legislative change in order to have who they listed in the bill provide the oversight.
Sandra?
2 things. I agree with Russ that getting the 8 to 16 months to implement the law was new and important. And also for me, nurses who are allowed to do their work have the most job satisfaction.
One more person may want to respond to, were there any new sources or facts that seem particularly strong and reliable?
Also, I believe Randy's earlier regarding the satisfaction of nurses and the efficacy, the fact that those lead to better nurse satisfaction as well as patient outcomes as well, and less costs. He made it very clear that the correlation is very strong. There is an argument for that in that regard.
Kimberly?
The unintended circumstances of hiring staff to investigate the questions, that was more reliable for me to look at that aspect of it. And yeah, it's unintended. That's what I meant to say.
Anthony, were you going to flip your tent? Okay. Thought I saw you reaching for it. All right. What new insights emerged? Did you want to respond to unintended consequences? You're on.
It just a law or regulation that is going through now nationally, which would address the situation in a different way. That was information that I did not have before.
So just one each? One from both sides? Okay, great. That's great. All right, flip a coin one more time. And you know, last time when I picked up, I had to look and make sure that both sides weren't tails. I'm sorry. at this point, I'm going to give this to the. And it is head, so we're going to hear from the pro first.
Just test. So what we're talking about is common sense. When you strip everything else away, this measure gives patients more time with and access to their nurse, so that when your loved one actually hits that call, they will be sure their nurse gets there when they need the most. Nurses are telling us that they are unable to provide the care patients need, which is leading to a variety of negative outcomes. And the statewide survey we've cited was not one isolated event. These findings were consistent in 2013, 15, 17, and 2018. The research is clear. When hospitals have safe beds, patient outcomes, there are multiple studies in the most prestigious medical journals that support what I'm saying to you today. In California, the results have been universally positive, showing patient outcomes, shorter emergency room wait times, low healthcare spending, and lower health and premiums than in Massachusetts. In addition, no hospitals have closed and no services were shed because of the staffing. Based on today's question and answer session, I wanted to clarify a few points. On membership and process, MA represents 23,000 nurses and healthcare professionals across Massachusetts, and you can find us in 73% of the state's hospital where this law would apply. In M&A, every member has a vote, and nurses collectively made the decision to put this on the ballot. The groups we hear cited on the other side don't all follow that same process. The Emergency Nurses Association, for example, decided to oppose this measure by a board vote. Under 10 people made the decision to say no. And as one of your independent experts noted, if you want to learn who is behind the opposition, follow the money. Research shows better care, nursing care, reduce costs. Nursing care is an intervention that prevents errors, preventable complications, and unnecessary increased lengths of stay. The raw cost impact of question 1 is a fraction of what the industry asserts. As Dr. Schindel Rothschild stated today, the implementation would cost over $47 million. Massachusetts hospitals generated more than $28 billion in revenue in 2017, and they posted profits of more than $1 billion. Hospital executives make choices about where to spend their vast resources. And our question is, why isn't it towards safe patient limits and stronger patient care? And I'll say this as many times as I need to. There is no nurses shortage. Massachusetts has one of the largest populations of nurses in the nation. There is no shortage of nurses. There is a shortage who are willing to work under safe conditions. Some additional points to clarify. This law would go into effect on January 1. But when you read the language, as the opposite side has encouraged you to do, and I do also, make sure you look at section 231B. It says that hospitals must have a plan in place to meet these limits. That's it. Any issue that is decided through a ballot initiative process takes time to implement, like this one, or like the marijuana legislation this program evaluated in 2016. It's a skeptic. Second, any claim that will result in patients denied care is not true. I can't stress it enough. The law mandates to receive care when they enter the ER. And I ask you to think about this logically. Do you think that if California saw lines of ambulances lined out outside because of the law, they wouldn't have? And finally, to the point in the expert panel about collaboration. This law actually puts a measure in place to ensure real collaboration in the form of an acuity tool. Right now, nurses, we're not part of that process. We're told to do the best we can with what we have. There are limits in daycare settings, but if your child's into a hospital, there is no limit. There are limits to the number of students a nurse can have, but no limits on patients. Fundamentally, there should be a limit. This bill would create that limit on how many patients